EC members log into Zoom or watch on YouTube? Pradeep is asking.
We are live on YouTube.
Yeah, no, Pradeep is asking, should the EC members log on to Zoom or on this one? EC members log into Zoom or watch on YouTube?
I have not given them the Zoom access, so they can't log in.
Oh, okay.
You want me to?
I'll just reply. No, I'll just reply to that message. I'll reply to the message saying this one. Should the EC members log on to Zoom or on this one? EC members log into Zoom or watch on YouTube?
I have not given them the Zoom access, so they can't log in. You want me to?
I'll just reply. I'll just reply to that message. I'll reply to the message saying.
If you want them there, I'll put them on. I'll give the EC the access for Zoom.
I just said on YouTube.
Okay.
Dr. Aditya cycles a lot, is it? You can see the bicycle at the back.
A bit, plus I don't have a second wall in my house, so this is the wall I sit against.
Oh, okay.
And I've been booted out of my room by the rest of my family, so now I'm in the hall. So
okay,
whatever I get,
okay.
I sit by.
But the cycling and all that, quite an avid cycler. You cyclathons like that, or?
Yeah, I mean, I enjoy my cycling. I don't normally do the large group cycling. We have a small group of friends who ride regularly and ride a lot. So I try and get out with them. And so we just ride in the city, sometimes outside, sometimes we do multi-day trips, whatever. It just depends on the season.
You get so much time as a radiologist. You get so much time as a radiologist.
I ride with Anand Joshi, so he has more time than me.
Yeah, that's what Dr. Anand Joshi does that. Yeah, he and Abhishek, I think they do. He does from Bangalore to Uti and all that kind of stuff.
Yeah, so I had gone with him on that trip. So we were together.
So you were there? Okay.
Yeah.
Right.
That was Bangalore to?
Bangalore Uti. We had gone to Munnar.
Okay.
It was Munnar, not Uti, is it?
That was how long
away? So the first day's ride is Bangalore to Mysore. And then the second day is Mysore to Uti.
So how long did that take you guys?
So it's a 9-day ride. It's called the Tour of Nilgiris.
Okay.
So it's a 9-day supported ride that you ride. So
how many people were you?
That is an organization that runs it. So there were about.
Hi Rajiv sir.
Hello. Hi, good evening, Dr. Daftri. How are you? Good evening.
My colleagues, Dr. Melanie and Ankita.
How is everyone?
All very well, sir.
Great. So we are all set for the evening.
I hope so.
Yes. Where's your glass?
Hey, where's the glass? I have to get my glass, I think. Is that allowed? Because I'm all ready. It's my time of day. Huh?
You're looking for my glass?
No, yeah. I'm looking for my glass. I will find my glass, especially if it's okay to have it. Because that's the only thing that's holding me back is the approval from the powers that be.
I can only provide the setting. Like you can just give a good nice.
I'm good. I don't need much of it. Nowadays, setting has become secondary. Nowadays, that's what's needed to make the setting.
Okay.
Your bike seems very impressive.
Thank you.
It means that you exercise a lot.
It means that I ride a bicycle. It means that my daughter doesn't go to college because I have a bicycle.
No, this is a symbol these days. It's not. It's a big symbol that you're exercising.
The bicycle is, as they say, cycling is the new golf.
Yep.
So, yeah, but no, I've been cycling for the last, I don't know, 8 odd years now. So
8 odd years, great.
No disease.
But otherwise, it's a good exercise.
It is.
It's a very good exercise.
Yeah.
Or Ajay, how are you doing?
I'm good.
I think we have a lot of time, so we can discuss about certain things. Did you talk to Arthrex people?
Arthrex, yes. Ruchir had contacted him.
Mm-hmm. He's lost on the way. So, Dr. Nathri, you do only musculoskeletal radiology or otherwise?
Primarily, yeah, I do mostly musculoskeletal
the
radiology.
whole team is doing primarily musculoskeletal radiology?
Yes. So Melanie has been with us for now. Melanie, what is it? 7-8 years?
7 years, yeah.
7 years. Yeah, we work together. So Melanie does a lot more of the MR side of things.
Okay.
Ankita trained with us, and she's probably stepped away for a minute or two. But she trained with us, went to Tata Memorial for a couple of years, and then came back and joined us. And she does MR, ultrasound, X-ray, plus the image, plus the CT guided injections and everything else. And I also do sort of everything related to musculoskeletal, from MR to ultrasound to the work. So the idea was to create a team of people who focus on musculoskeletal issues, and who, it doesn't matter for modality is not really a limiting point for us. So that way you're not saying please correlate with the radiograph, or please correlate or please, so we like to work in that environment. And we've been fortunate that we've had good people to work with all along. So it's given a lot in terms of our own learning and understanding of musculoskeletal conditions. So that's been
I know it is very important. Most of our diagnoses are dependent upon this radiology as far as orthopedics is concerned.
right.
And we as orthopedic surgeons are not very much familiar with these modalities and all that.
Yeah.
So I think if you just stick to more of a basic to identify the structures and how to pathologies, that will be much better, because this is probably what we are looking for.
Yeah.
Because we are not at all trained, musculoskeletal MRI readers or something like that. We actually want to know the basics.
So we've actually structured it that way. So Melanie is a fabulous teacher, and she sort of has a very good structured approach of going through the MR anatomy and understanding how to look for the common structures that you need to look for. And then the way we sort of went around structuring also the talks was a little bit broadly based on how you would see things in a clinical scenario.
Yeah, that'll be much better.
So that's how the talk is structured. That's how they're structured. So even, why would you image a person with instability? What would you expect to find? What would you be looking for? How would it help with your decision-making process?
I've seen you a number of times in a clinico-pathological radiological meetings with the MSOS.
Yes.
So we happened to meet there once or twice, but
Right.
I was more often in the audience in that.
Yeah. That's an interesting, it's a nice meeting because I think it brings all the specialties together. And again, I think that is in general what we as a group have been promoting is we need a lot more cross-specialty training, cross-specialty respect and understanding. And I think, that's why I enjoy dealing with orthopedic meetings a lot, because it sort of puts you where you really need to be and gets the word out of what you're doing and how you can understand what's happening through that. So
me and Sagar have been, friends, work together in Oswal at one.
Okay.
So at some time I had a passion, but I still have passion for orthopedic oncology.
Yeah.
I got trained in with Grimer in Woodlands in UK. But then I left Oswal, and after that I couldn't click into some place which was primarily devoted to orthopedic oncology.
Right.
Then I developed special interest in foot and ankle, and which I've been pursuing for last, I think, 8 to 10 years now. I'm more of a foot and ankle guy, but still I do quite a lot of benign tumors, and sometimes even endoprosthetic replacements when I don't need much backup of radio and all that. Like you get a primary osteosarcoma, you send the patients and the patient get 3 cycles, and after that they come back to you.
Right.
And then like chondrosarcomas, you don't need of diaphyseal. I don't go to pelvic region, but distal extremities we do almost all excision arthrodesis, arthroplasty. Still we are doing it.
So Melanie handles a lot of the tumor work at our practice. So between Melanie and Ankita, because Melanie goes a lot to the tumor meetings and is involved with the tumor people. Ankita, because she also was at Tata for a while, so she has an interest in oncology. I get dragged into the oncology meetings, almost kicking and screaming. but
our
yeah.
hospital is now thinking of some oncology setup. So if they
Yeah.
just, then maybe I have to do that again.
But I think it's nice, because they have developed a very nice way in which there's a mutually respectful orthopedic oncology group through something like
Yeah, yeah.
IFAS.
It's
So
very good.
you have a very open platform to discuss cases,
Yeah,
to get help, to figure out what you can and can't do, what you should and shouldn't do, and I think that's really nice.
We have these weekly meetings, Hinduja and Tata.
Okay.
So again, ortho, radio, pathology, and cases discussed, imaging appearance, immediately pathology discussed there. So very interesting. Each one learns from the other.
Yeah, that is very important. If we actually want to, give good treatment to the patient in oncology, this is the most important thing. It is just a team approach. It is very difficult. That is why I do less, because the moment I think that you need a team approach for this, then I get, a drawback there. I don't find the team. So where I think individually I can do something, but maybe after some time I may have to, once again start oncology once our hospital starts it.
But even it would be sort of interesting if IFAS looks at, this whole concept of multidisciplinary conferences is now becoming so much more of a reality. And now in this last 2 months, everyone has become so used to Zoom and remote conferencing and that kind of stuff. It's a great opportunity to build something where you have sort of a monthly meet or something where people get to show, and you have somebody who moderates it really well, who keeps the discussions short, so it doesn't drag on. It becomes, all right, this was a case of this, what would be the appropriate management, or why would you potentially not diagnose this and manage it incorrectly? Some things like that would be good for young, because I think foot and ankle is probably that segment of orthopedics that is now growing a lot more. In the last, I can remember that when I came back, there were not many people dedicated to foot and ankle, and now you have the society that's much more active and many more people. And I think young orthopedic surgeons are seeing that there's a lot of saturation in the plasty world, a lot of saturation in the scopy world, a lot of saturation in the in the tumor world, and this is sort of the next area. And with sports increasing, this is becoming obviously a big area that people need to be more interested in.
Good evening, Dr. Ankita.
Hi, sir.
Hi, how are you?
I'm fine, sir. How are you?
Very fine. Thank you very much. But then foot and ankle is really, we always do more of a case-oriented, webinars, or even our conferences are also case-oriented. We don't look into something like more of a lecture, but this is one thing which we don't know. That is why we are up to that. We at least learn the basics, and then we can. And how much is the time? We have 5 more minutes.
5 more minutes. 5 more minutes.
Yeah, we have 5 more minutes to go. And so we were talking something about arthritis.
Yes.
So any reply from them?
Yeah, Richard said he will, and he had asked for this one. He wants he has given a pro forma invoice kind of a thing for the letter.
Just send him the IFAS, your account.
Okay, account details and all. Yes, I'll do that. I'll do that today. So I was trying to tell him that being a society, we might not be able to give an invoice as such.
I told him. I told him that we won't be able to give it. You want a receipt, we'll give it to you.
Yeah, we can just type it on the letterhead and give it to him that we have received this amount for.
Yeah. We did similar to
receipt is there. Receipt book is there.
Advanced category course. We did the same thing.
Yeah.
But now what he wants is, he says that in case it has to go as a sponsorship, then he has too many permissions to take and all. So now he's showing it as an expense towards the utilization of the our this thing platform.
So whatever it is basically the IFA should get more. So that is it.
That's all.
Yeah, that's true.
But that is what we are looking for.
But giving an invoice, how safe is it?
Because it's a day after, so I thought if we can give it something earlier.
Yeah, no, but is it okay to give an invoice? He wants a performer
Next,
invoice.
Indrajit, next is with Abhishek is going to plan everything, our third Friday. So Abhishek Kinney. So I've just given him, so he's gonna do something.
Okay.
So I have to contact him. I want a program for that. And your journal clubs are ready, boss? Ajay?
Journal club is ready. In the sense, I've made the two groups. There are 6 people in each of them. Then to lead them, I was telling
So
you, I'll
just
just
give
request a
whatever it
payment.
is, he can make the flyer for it. Indrajit can make
Okay, done.
That can be done, sir.
Done.
Yeah. So
Once we finish deciding the topic, we can make the flyer.
that he has
Okay.
already done, I think.
He's still
Yeah,
finding
so
out 2-3 topics.
This is entirely between you and him. I am out of it. I am just
No problem, sir. We'll figure it out.
so I'll finish
तो
this.
वही रखते हैं. We'll do outcome measures only. वही करते हैं.
Okay,
अच्छा रहेगा वो.
that's
Now
fine.
we're live on YouTube. I think we should start.
Okay.
Okay.
You have something on YouTube, participants or something?
We are running the whole stream on YouTube, sir. It's running.
Okay.
Now.
So good
Yeah,
evening.
people are joining in because I've shared it with my postgraduates also.
Okay.
They are also joining in.
86 people have joined in already.
86.
26.
Okay.
Oh, that's good. So
that's
good
a
evening.
lovely number.
We can start, right? So good evening, the participants and the speakers present for this webinar, which is entirely devoted to the musculoskeletal radiology in foot and ankle ailments. I'm extremely thankful to Dr. Aditya Dasari as well as team who have agreed to enlighten us on MRI, because this is very regularly what we see in our day-to-day practice, that everyone comes and give us an MRI. And then the first thing we ask is, where's the report? Because we don't understand much about where to look for the pathology and what is the pathology. So I think if we can learn something that we can at least make out the clear-cut pathologies from the MRI, it will be a great help. And thank you very much, Dr. Aditya. I would like to introduce him. He is a consultant musculoskeletal radiologist with the special interest in diagnostic and interventional musculoskeletal imaging in Innovation Imaging, Mumbai. Welcome, sir. And to team with him is Dr. Melanie Lavande, who is also a consultant musculoskeletal radiologist with more than 20 years of experience. And he has been speaker in many national as well as international radiology meetings. We welcome you, ma'am. And then I welcome Dr. Ankita Huja, who is also a fellowship trained consultant musculoskeletal radiologist with interest in diagnostic and interventional musculoskeletal imaging. And she has been speaker in many national conferences. It is an honor for IFAS to have you us with tonight. And I hope that we will benefit from today's webinar. And I request Dr. Dasari to take the charge.
Okay. Thank you so much for having me, Dr. Vora. Thank you for this opportunity. I think what we have set out today to do is try and deal with the agony of defeat, which is defeat and the ankles. So what we will be talking a little bit about is how you can use MRI in your practice, or how we as radiologists can help you with MRI. What you'll find is the curriculum is fairly is simplified a little bit. We've put it down into anatomy, which Dr. Melanie will go through. Then how you would look at imaging in a case of ankle instability or an ankle sprain. And then subsequently, we've talked about the talar osteochondral lesions, or the osteochondral lesions in general in the foot and ankle. We'll talk about flat foot and the posterior tibial tendon, the great toe, and then we have a segment on the midfoot. So hopefully this covers what are the common areas in which you would use MRI. And what we're hoping to give you is some quick clues in terms of when you're looking at MRIs, how things can help you, and some quick clues on what you should be asking of your radiologists when they are giving you reports to say, listen, I know this is the information that I can get. Can you sort of do a better job at getting me that information? And I'm sure once you put those questions to them, they will come back with those answers in a more definitive way. So I won't waste any more time. I will hand over the mic.
I would request that because the spectrum is different in different talks. So if we have the question and answers after each talk, that will be much more easier.
Sure, absolutely. So we'll do that. So we have, I think each talk is set up to be no more than 15 to 20 minutes. That's usually enough time to keep everyone's attention span. You have maybe 5 to 7 minutes for questions in between, which is obviously at this time of day enough time for everyone to grab a drink and bring it to your table. And hopefully we'll try and keep this engaging, interesting, and light, just to and more practical. So I, without any further ado, let me just hand it over to Melanie. And Melanie, if you take over and share your screen and start with the anatomy, please.
Thank you so much for this invite. And what we'll do is we'll start with the very basic, and that is we'll look at anatomy and the sequences. Is my screen visible?
Yeah.
Yeah. Okay. So what we're going to do now is look at the MR anatomy and the signal. So let's start with the very basic, and that is what are the sequences that we normally use when we look at MRI. Unlike CT, you don't have only a simple CT. Here you have multiple sequences, T1, T2, stir, which can at times be confusing. Then we look at how do structures look normally on these different sequences. And then we look at the normal anatomy of ankle, and we'll restrict ourselves to the very important structures which we need to look at. So just in less than half a minute, how exactly is an MR image formed? Patient lies in the magnet without all this complication. Patient lies in the magnet, a radio frequency pulse is sent in, and then an echo is received by this receiving coil. So this coil is different for different parts of the body. So for ankle, we use a coil which is shaped according to the ankle, which will cover only a small field of view, including the ankle and the foot. And this signal which is received is then by complex Fourier algorithm converted into an image. Some tissues will give out bright signal, some tissues will give out dark signal. So this is calculated, is given different shades of gray, and you end up getting an image like this. Now, you send in a pulse and you receive a signal. By changing the time between this, you can get different kinds of sequences. So, which are the common sequences that we use is a T2 weighted image, but instead of routine just T2 weighted image, we suppress the fat. In T2 weighted image, the fluid looks bright. So we know it's a T2 weighted image. And why do we suppress the fat? Because adult bone marrow is all fatty marrow. And fat also looks bright on T2 weighted image. Fat looks bright, so does any pathology. Most of the pathology would be marrow edema, whether it is marrow contusion or tumor-related marrow edema, infection-related marrow edema. The marrow edema is bright on T2, and so is fat. So you cannot distinguish. So what we do is we suppress the fat. If we make all the fat look completely dark, this is normal. So here you can see in the talus here, there is bright signal. So immediately it catches your eye that this is marrow edema in the talus. So this is an essential sequence, a fat saturated T2 or a stir. Both of them are kind of the same sequences where fat is made to look dark. Then we have a proton density image, which is a very good image to look for all kinds of internal derangements. Why? Because it can show us the cartilage very well. As you can see here, this black line is the cortex, and this gray intermediate signal intensity here is the cartilage. So you can see the cartilage very well. And also your fat still looks bright. So it outlines all the ligaments and tendons very well. You can see the peroneal tendon here. So this is the mainstay of imaging. We don't need any dedicated additional cartilage sequence. This routine sequence can show us ligament, tendons, as well as the cartilage. Then we have a T1 weighted image, which is not very good to try to evaluate the cartilage or the ligaments and tendons. Why? Because the fluid is dark on T1, and so is the cartilage. So everything kind of looks homogeneous. But we do use T1 when we are trying to look for marrow pathologies. Otherwise, when we are looking for ligaments, tendons, and cartilage, the two main sequences we look at are the FATSAT T2 weighted image and the proton density image. Now, how do different structures look on different sequences? Let's begin with fat. You can see all this subcutaneous fat here, the heel pad fat. Fat is bright on T2 proton density as well as T1. On all the sequences, fat is bright. This being a fat saturated T2, that's why the fat has become dark. That's how we identify that this is a fat saturated sequence. Next, coming to fluid. If you look at this joint fluid here, it is bright. So this is a T2 weighted image. T1 weighted image, the joint fluid looks dark. And on a proton density, the joint fluid looks bright, but not as bright as on T2. It's not standing out that much. Next, coming to tendons, ligaments, and fibrocartilage. You can see the Achilles tendon here, here, and here. And in all of these, the tendons look completely dark. Why? Because the signal coming on the MR image is due to the hydrogen protons, the hydrogen predominantly in the water. And because of tendons, ligaments, and fibrocartilage, they have a very tightly packed structure. So in tendons, you have, and ligaments, you have the collagen fibers very tightly packed. So there is no place for the water molecules to move at all. So they are not giving any signal, and we see the structures as completely dark. So fibrocartilage also, so menisci, labrum, all of them are dark. Next, coming to hyaline cartilage. So if you look at hyaline cartilage, which is the articular cartilage, it is intermediate signal intensity, gray on all the sequence, because there is little more place for the water molecules to move. If you look at the muscle, so here we can see the plantar compartment muscles. The muscles look gray. In fact, whenever we describe some lesion as hyper intense, we mean that it's more bright than the muscle. So we take muscle as the baseline. When we say something is iso intense, we mean it's as gray as the muscle. And when we say something is hypo intense, we mean that it is darker than the muscle. So muscle we take as the baseline and compare the signal in relation to it. Next, coming to bone. In adults, there is fatty marrow in the peripheral bones. So the marrow looks bright on T1 as well as proton density sequence. And T2 also. Only when you suppress the fat, make it fat saturated, the marrow looks completely dark. Now, having looked at this, the three planes in which we evaluate all the scans would be, just imagine a bread being cut into slices. All of you know the anatomy much better than anybody else because you're seeing it all the time during surgery. You just have to imagine it in different planes. So cutting the ankle from medial to lateral, the sagittal images, superior to inferior, the axial images, and from posterior to anterior, the cornal images. The same structure, how it would look on three different planes is what we need to look at. So now let's start looking at the anatomy on MRI, and we'll go through them, the most basic imaging structures. So first, let's begin with anterior talofibular ligament. So imagine an axial plane at the level where the talus is looking almost like a dumbbell shaped or figure of 8 kind of appearance, and where the fibula is almost ending here. So we can see this structure. As I said, all ligaments, tendons, fibrocartilage are dark on all sequence. So all ligament, all tendons look completely dark. So here you can see the ligament extending from fibula going to the talus. This is the anterior talofibular ligament, the most commonly injured ligament. And this is how it would look normally. Now imagine an axial image. So axial images are best to look at the anterior and posterior talofibular ligament. So imagine a section passing here at this level. And again, you can see the talus still has that figure of 8 like appearance. And now, if you can see here, this is the other side ankle which I've taken here, but you can see this is the anterior talofibular ligament, and at that same level is the posterior talofibular ligament. Towards the talar attachment, it has more fan-like appearance with little striated appearance. It's not completely dark, and that is normal. Posterior talofibular ligament can have this kind of striped appearance near its talar attachment. Next, coming to the calcaneofibular ligament, which goes from fibula to the calcaneum here. So if you imagine axial sections passing at this location, best location is to start tracing it from the fibula. This is the fibular lower end, and this dark structure here is the calcaneofibular ligament. As you go inferiorly, these are the peroneal tendons. You can see here, going from the retromalleolar groove inferiorly, between the peroneal tendon and the calcaneum, you start seeing this thin black band. That's the calcaneofibular ligament. Trace it further inferiorly and you can see it going to the calcaneum. But calcaneofibular ligament, as we know, is located in the coronal plane. So it's best imaged in the coronal plane. But it will not be seen in one slice. So start looking at it. So in the posterior section, start looking at this black line, that is this calcaneofibular ligament. You can trace its mid substance and then you can see it going up to the calcaneum. This is the peroneal tendon. So between the peroneal tendon and the calcaneum lies the calcaneofibular ligament. Next, looking at the deltoid ligament, we know all the components, but while we are imaging, we are primarily looking at the deep component of the deltoid ligament. The superficial component, only the tibiospring ligament is seen consistent. Tibiocalcaneal and tibionavicular are of varying thickness in different people, so we are not really looking at them all the time. So on a coronal image, if you look at the medial malleolus, you can see this fan-shaped structure going from medial malleolus to the talus. And again, it has got this striped, striated appearance, and that is the deep component of deltoid ligament or the tibiotalar ligament. Again, it normally has this little striped appearance because there is fat in the synovial recesses. From calcaneum, from the tibial medial malleolus, you can see a ligament going down like this, quite relatively thick one, and that is the tibiospring ligament. It's going towards the spring ligament. Here you can see this thin flimsy structure from tibia to calcaneum. That is the tibiocalcaneal, but we are not really evaluating it every time. And as you come more anteriorly, this thin here is tibionavicular. But as I said, we are mainly looking at this deep component deltoid and this tibiospring ligament. Next, coming to the syndesmotic joint. So if you imagine a section at this level to look for the anterior and posterior inferior tibiofibular ligament. So this is where the talar is just about beginning. You're seeing it, because the tibial plafond is ending and the talar dome is starting. And you can see here, this dark structure is the anterior inferior tibiofibular ligament. This dark band here is the posterior inferior tibiofibular ligament. On a coronal image, if I imagine if we look at the fibula and tibia, you can see this structure, intermediate gray signal intensity going obliquely. So that is the syndesmotic ligament, which is thickening of the inferior portion of the interosseous ligament. Next, coming to spring ligament. Again, we are primarily evaluating only the superomedial component. We are not looking at the intermediate and lateral band because most of the times pathology, this is what is involved. And we can see how it lies close to the tibialis posterior tendon. This is tibialis posterior tendon, and just deep to it, this structure, this black band here is the spring ligament on an axial image. If I look at the same thing on a coronal image, this we already said is the tibiospring ligament. And as I come more anteriorly, I can see this ligament kind of forming a hammock-like thing. It helps in maintaining the arches also. So that is the spring ligament superomedial component. On the sagittal images, this here is the sinus tarsi, which will contain the talocalcaneal and the interosseous ligament. Normally, it should not show much bright signal on the T2-ated image. If we see bright signal, then it is edema, because normally it just has fat, which becomes dark on the fat-saturated T2-ated image. Lastly, looking at the tendons, let's start with the Achilles tendon. You can see the myotendinous junction, the soleus muscle here, Achilles tendon, insertion, retrocalcaneal bursa location. Here is the area we look for Haglund deformity. On an axial image, Achilles tendon looks like a little elliptical structure. Anterior margin is little concave. If you have it bulging, if it becomes circular, then it is tendinosis. Same here, anterior and posterior margins are parallel. If it becomes not parallel, if it's swollen, then you know it is tendinosis. Let's look at the medial tendons. Tibialis posterior, flexor digitorum longus, flexor hallucis longus. Again, tendons look dark on all the sequences. Best way to remember: Tom, Dick, Harry. Tibialis posterior, flexor digitorum longus, flexor hallucis longus. Normal tibialis posterior tendon is about double the size of FDL. So that's the way to look at it. If it is much more larger, it is tendinosis. If tibialis posterior is smaller than the FDL, then we know that it is torn. There is some abnormalities attenuated. This is FHL here. Flexor hallucis longus tendon sheath communicates with joint cavity. So if you have some fluid here, it's fine. Only if it is disproportionate to the joint fluid, we'll call it tenosynovitis. This is tibialis posterior, FDL, FHL. As we trace it, we can see the tibialis posterior inserting to the navicular. And this is the location where we can see the FHL in this groove. This is the Steda process. You can get impingement there. And this here is the knot of Henry where FHL and FDL cross each other. On the sagittal images, you can see the tibialis posterior inserting. Look here carefully for accessory navicular. Next is the FDL going into the foot like this. And then is FHL going below the talus into the foot. Coming to peroneal tendons. Peroneus brevis is thin, anterior. Peroneus longus is thicker, posterior. Retromalleolar groove. This thin structure here is superior peroneal retinaculum. This structure here is tarsal tunnel. You can see these vessels. As you go inferiorly, you can see the peroneus brevis anterior and the longus. Peroneus brevis inserts to the fifth metatarsal base and longus goes under the cuboid. Sagittal images, you can see the brevis and the longus. Longus goes below the cuboid. Look carefully, this area there can be impingement. Lastly, the anterior extensor tendons. Now this is Tom, Harry and Dick. Tibialis anterior, extensor hallucis longus and extensor digitorum longus. And below that here are the peroneal neurovascular bundle. So these can get impinged by osteophytes or some pathology here. Again, tibialis anterior, extensor hallucis longus, extensor digitorum longus. On sagittal again, they can be traced like this. Most important, all structures are best seen on axial images. So we first look at axial images and then look at other images to corroborate. And this is the extensor digitorum longus. So quick recap, we looked at sequences: proton density, fat saturated T2, T1 weighted image. We looked at how all tendons and ligaments look dark on all the sequences. Hyaline cartilage looks gray signal intensity on all the sequences. And we went through anatomy of the important structures, that is the lateral and the medial ligament complex, syndesmotic ligament complex, as well as the tendons around the knee. Any questions? I'll be happy to take.
Indrajit, are there any questions?
No questions, sir, as of now.
I think she's made everything so beautiful. Everything is as if we are seeing, we will be able to understand the anatomy when we see the MRI.
Of radiology.
Provided we get these good MRIs.
Exactly. That's very thin. He's taken those proper cuts from the, the system and shown us. We don't get such good images when we get.
You just need to have low field of view images, and you can get images like this all the time. So any problems, we can always guide the radiologist also the protocol to be used.
Actually, you take almost 1,000 images on computer, and we get like 64, 70 images on the screen.
CT we take 1,000 images. MRI we take only about 20 images. They are not much.
Okay.
Any Tesla recommendations when we are referring the patients to the, do you find that in foot Teslas make much of a difference whether we should get a 3 Tesla or not?
So frankly speaking, between 1.5 and 3 Tesla, yes, 3 Tesla does show the cartilage much better. Okay. But having said that, I don't think there is anything that you will not see on 1.5 Tesla at all, but see only on 3 Tesla. You will only see it better, slightly better on 3 Tesla. So I would say it's essential. If you have it, fine. If not, a 1.5 Tesla with proper protocol and images done like this would be fine.
Would be fine. So when, particularly when we want to see some cartilage pathology or something like that, there we should look for 3 Tesla. Otherwise, in most of the
ligaments,
routine
tendons, yes. Mainly 3 Tesla helps us in shoulder, labrum, those areas. Ankle, it would be fine without it also.
Because this is one dilemma which a common orthopedic surgeon has when he has that he thinks that 1.5 Tesla won't be able to show that much, but actually this is not the fact. That if you want to see a cartilage something, so there you may ask for, otherwise even a well done 1.5 Tesla is good enough.
It would be enough.
The proton density is always done as a part of the thing, or should we specifically request?
So what happens is, unfortunately in radiology, there are no standard protocols because each time studies are tailored according to the findings. So these are the proton densities are always essential for the internal derangements. If you are looking at a tumor protocol, it's different, which I didn't speak about here at all. So knowing what the scan is for makes a big difference. If you know that it's for not for a lesion, it's for looking at ligaments and tendons, then a proton density should be done ideally all the time.
Okay. So
I don't know. There's one question which shows which asks that how do you identify the peroneus tertius?
Okay. So there are many accessory muscles and bones in the ankle. So what we do is I showed the peroneus brevis and longus. If we see an additional tendon, a muscle extending there and an additional tendon, then that is how we would identify peroneal tertius and peroneus quartus.
I think more important is peroneus quartus than peroneus tertius because of the posterior.
Yeah, we have lots of accessory muscles and bones. So anytime you see something which is extra, an additional tendon, additional muscle, in addition to what I showed in these images, then you have to start looking at these normal variants.
Is another quartus generally missed out? Is the peroneus quartus generally missed out or something in the reporting?
Yes. Because if you're not looking at it carefully, it's possible to miss that out.
If you have a peroneal tendon symptoms, I think we need to look into it because this is where the whole thing becomes stuffed in and they can lead further decrease the volume of the tunnel and lead to the peroneal tears predisposed.
So that's important to be very well versed with the normal anatomy. So then anything which is additional is easily picked up and then you can figure out what
reported.
There's another question: how you look for basset ligament, which is one of the causes of the anterior, ankle impingement.
Okay, so I think Aditya is going to cover impingement. So we'll
Okay.
But all structures can be seen on MR if we just know where we are supposed to look for it.
How important to position the foot? That is.
Yes. So normally foot when it is positioned should be just slightly about 15-20 degree plantar flexion. We don't want too much plantar flexion or too much dorsiflexion because what happens, the tendons should not, if tendons are at 55 degree to the external magnetic field, the magnet, you can get artifactual signal in them and we may wrongly think of them as tendinosis. So just to keep, but again, that is not really a problem because we look at all planes, axial, coronal, sagittal, not only one. But ideally, just about a little plantar flexion, not too much of plantar flexion. Otherwise, it gets kind of distorted when there is too much of plantar flexion.
So there's one more question, which is how we get confused between the second and the third metatarsal and how actually you distinguish actually where you are. I think that shouldn't be a problem if you can see the keyword.
If we take all the three images, always when you're looking on the console, we have axial, sagittal, coronal. So we know exactly where the image is taken from on the other two planes.
On to you, Dr. Aditya.
Okay. All right. So I think we've answered most of the questions. I think one of the things that we mentioned is what Melanie said was you can take the axial, sagittal, coronal images all three on one. And when you're looking at it on any of the digital viewing devices, then you can do something called triangulation. So if you click on one spot on one of the images, it'll automatically with a cursor show you the other spot. So if you identify the structure on one, then you will be able to identify it on the other as well. So that's just the easier way to do it than to get into anything longer. Somebody asked about channels. That's just a technical thing. If you have more channels, you get better images. And I think that's there. But I think that takes care of most of the questions. So I'll move on to the next bit of this talk. And let me just share my screen. Okay, and let's get here and where is this go? Okay. So is my screen visible to everybody?
Yes, it is.
Okay, great.
Yeah.
Okay, so we're going to talk now about ankle instability, and I find this area rather fascinating because it gives me I believe it's the root of all evil in the ankle. So what I'm going to try and do is use this to give you some insight into how I at least look at ankle instability and how it affects the ankle in so many different ways. So to start with, we'll talk about why we want to image ankle instability, what we can see when we look at the ankle for instability, and how does that generally affect management. So here's a slightly complicated table, but I'm going to simplify it. Essentially, why do you image an ankle sprain? And the reasons you image them in the acute situation are either because it looks much worse than a normal ankle sprain. Either that, or secondly, you expect it to get better in a week or two, but it's still not better. So these would be two big reasons why you would image the acute ankle sprain. And in those situations, what you're looking to see is the problem primarily in the ligament? So am I missing a high ankle injury? Have I got a bad low ankle injury? Or have I got midfoot ligament involvement? Am I looking at an osteochondral lesion that could be the cause of the problem? Am I looking at the tendon itself, especially the peroneal tendon, which could be a problem? These would be the common areas that you would be looking at. The second group of patients you would image are those who have recurrent ankle instability. And in those cases, you're trying to understand, what is the status of the ligament? Is it well remodeled, poorly remodeled? Is it the bone involved? That kind of stuff. You want to know what the status of the cartilage is, obviously, because if there is bad cartilage, no matter what you do, the outcome of the prognosis is not going to be so great. And then last but not least, you want to know the dynamic effects of instability, which is essentially impingement and the sinus tarsi syndrome. So determining all of these factors is what helps you to understand whether you should take a path of just reassurance of the patient, offer a surgical alternative, and if the surgical alternative is offered, then what the surgical alternative is. So the first thing I normally do when we're looking at any person who comes with an ankle sprain is we look for bone marrow edema, which is what Dr. Melanie showed you, and fractures. And the common fractures we want to look for are obviously involving the fibula. So obviously, if you see a fracture that is above the level of the syndesmosis, then that is a clear indicator that you may be dealing with a high ankle injury, and therefore the management has to be different. You're dealing with something that may require surgical intervention. If you're dealing with a low fracture, then you're saying, okay, this is still below the syndesmosis. It's a fracture. So I can tell you, instead of you're hobbling around in 2 weeks, you're going to take 6 weeks before you start hobbling around, and you better take care. So it helps you in that sort of decision making or reassurance for your patient. The other area that you do see often edema is in the talar head at the plantar aspect. It's an impaction injury. Sometimes you'll see fractures of the anterior process of the calcaneum. And then sometimes you can even see fractures of the cuboid. So the identification of these non-displaced fractures really, more than anything else, helps to reassure your patient that, look, you have a fracture. It's a subtle fracture. It's going to take some more time to heal. So I know every other ankle sprain of yours recovered in 2 weeks or 3 weeks. This one is going to take 4 to 6 weeks. And we're going to make you spend on a boot so that you can be more stable and comfortable. And your rehab time may take a bit longer. The other thing, so these are a clue to a condition that may need something else. I'm not going to focus on the talar osteochondral lesions because Melanie is going to talk about those. Once you've looked at the bone edema and the bone swelling and the presence or absence of a fracture, the next thing I tend to turn my attention to is a high ankle injury. And the high ankle injury is important because oftentimes these injuries require a surgical management. So when you're looking at high ankle injuries, what you're looking at is what Dr. Melanie told you about, the syndesmotic ligament, or the thickening of the inferior portion of the interosseous membrane, which you can see normally as this little band. So what you'll notice in this talk is anytime I've shown you a normal structure, it'll be with a green outline. Anytime there's something abnormal, it'll be with a red outline so that you know which is which. I haven't used black and white because these days, basically that becomes a racial issue. But here you can see the interosseous membrane here. And here you can see how it is thickened and hazy. So this is an intermediate grade injury of the interosseous ligament. Here you can see the normal anterior tibiofibular ligament and posterior tibiofibular ligament, whereas here you can see there's complete disruption of that ligament from its tibial attachment. Here you can see an intermediate to high grade injury of the syndesmotic ligament, again an intermediate to high grade injury of the anterior tibiofibular ligament, as well as some thickening and edema. But not only that, you can see this subtle chip fracture of the posterior malleolus, which indicates to you that the entire syndesmotic joint is involved, and therefore this is something you may need to manage surgically rather than just leave in a boot, or this person could develop long-term instability from this. Once you move from looking at a high ankle injury, which is essentially the big ligamentous injury that you don't want to miss, you go back to looking at your normal ankle injury, which is most often the anterior talofibular ligament. Now you've seen the normal anatomy of the anterior talofibular ligament running from the talus to the fibula. You can see this black band here. This is somebody who has a little bit of high signal, maybe a slight thinning of that band. And this is somebody who's got probably a low grade injury, or this could also be a partly remodeled older injury. Okay, so this would be what would be essentially grade 1. You can see on a grade 2 injury how that ligament is significantly more thickened and edematous, but the ligament is still continuous, and that would make it a grade 2 or an intermediate grade injury. And then the third one here you can see is complete disruption from the talar attachment. You can see it sort of dangling in the breeze over there, and that's a high grade or a grade 3 injury. Sometimes that can happen with an osseous avulsion, and sometimes it'll be just a soft tissue injury. Now, the other thing that happens with these injuries oftentimes is you will see that there is also an associated capsular rupture. And because of that capsular rupture, there's a large pericapsular leakage of fluid. And that's what makes that ankle look really big and swollen and edematous with the hematoma. So sometimes just seeing this large amount of soft tissue edema more around the area of injury is, is enough to tell you that, yeah, this person has a big capsular leakage, and that's why there's all this edema around here. So it's still a low ankle injury, but it looks bad because there's been a capsular rupture. Okay, so these things are helpful for you in terms of being prognostic indicators. A patient says, how much time will I take to get better? Yeah, it's a minor injury. You should be okay soon. How much time? It's a bad injury. It's going to take longer than we expected. Plus, you'll need to do a lot of rehab to get back into place. The calcaneofibular ligament, here you can see the normal calcaneofibular ligament, and here you can see somebody with a thickened and edematous intermediate to high grade calcaneofibular ligament injury along with a Weber A fracture of the distal fibula. So this is where you can see the calcaneofibular ligament. The deltoid is a ligament that's also important to notice, because rather than the posterior talofibular ligament, most of the time it's the deltoid that goes first in a patient with a bad ankle sprain. And obviously when there is deltoid involvement, it indicates that it is a more significant ankle sprain. And you may see this by means of edema in the medial malleolus, or you may see this by means of actually seeing this ligament here. Now you see this ligament, it's a relatively normal ligament. It's got this triangular deltoid shape to it. And if you look at the fibers within, I can take a pencil and I can draw those little fibers within. And that's what makes that a normal deltoid. Whereas here, if I look at this deltoid, it's just, all this ugly material over here. And it's that ugly material there that essentially tells me that this is actually an injured deltoid and this is a normal deltoid. And similarly here, you can see this ligament is nice and black, which is a normal deltoid, whereas this ligament is bright T2 signal, which is an abnormal deltoid. So this is in terms of your medial sided ligamentous injuries. The last thing you sort of end up looking at is the peroneal tendons, because oftentimes when you have an inversion injury, as you do with an ankle sprain, the body's natural response is to produce an eversion force, which is provided by the peroneal tendons, and therefore you can see splits and injuries in the peroneal tendon. So you may see everything. So here you can see this is a nice, slender, normal appearing peroneal retinaculum, and here you can see this peroneal retinaculum is thickened and edematous and ugly looking. So you can see a peroneal retinacular injury. In this case, you can see the peroneal tendons should ideally be sitting in the back here in the retromalleolar groove, but here you can see that they have moved sort of anteriorly. So you see there's rupture of that retinaculum, and the ligament has subluxed anteriorly. And then in this case here, you can see this is the peroneus longus, this is the peroneus brevis. This is the brevis here, and this is the longus here. And in this case, what you can see is you can see the famous Mickey Mouse sign. So this looks like Mickey Mouse. If for those of you who go to Disneyland and remember those things, this is the Mickey Mouse sign, because you have a split in the peroneus brevis, and the peroneus longus is sort of coming in between them. So if not anything else, you will remember Mickey Mouse, and that will give you some idea of what it is. So here's Mickey Mouse with his ears, the face, and the mouse. And when you see that, that's a good sign that somebody has a peroneal tendon split. And then that's again an indicator for you to say, aha, I probably need to go in and operate or do something for this person. So again, these will change your management plans when you start to see these findings. So what I've done so far is we've talked about the situation of the acute ankle sprain, and we've given ourselves understanding of why an ankle sprain looks worse and how we can reassure somebody that no, you don't need surgery, but it's going to take longer to heal, or no, you have an injury that is probably going to require a surgical management. And if so, then what is the surgical management? The second situation that we run into most often is the situation of the recurrent ankle sprain. And here what we're trying to determine is what is the status of the ligament, what is the status of the osteochondral lesions, and what is the dynamic changes that we see. So here is a situation where you can see, we saw that normal anterior talofibular ligament, and you can see the ligament here, but you see that at the talar attachment, the ligament is really gone. So you know the injury here and attenuation is at the talar attachment, as opposed to this case where you just really literally have a thread thin ATFL remnant. So we can tell what is the quality of the tendon, which side it's gone more towards, whether there's bony involvement or not. And this would help you in terms of when you decide to reconstruct, how you're going to reconstruct this tendon, the ligament, sorry. I won't go into cartilage changes. The next thing is, once you do have ligamentous instability, what you end up having is micromotion. And when you have micromotion, you have synovial thickening, you have osseous change, or you have exaggerated effects of normal structures due to micromotion. And this leads to impaction upon the tendon and the neurovascular bundle, which is essentially the impingement that you see. So we have anterior impingement, which could be bony because of bone on bone, where there's actual bone block. So you can see here there's a talar neck bony spur and a distal tibial bony spur. And these two spurs will cause a bony blocking to plantar to dorsiflexion. You can sometimes have bony avulsion of the ligament, and that bone fragment sits in that synovial space and causes impingement. Or you can have scar tissue that forms along the anteromedial or anterolateral aspect of the joint, which then impinges upon either the extensor digitorum tendon or the traversing neurovascular bundle. So because of the instability, you have a reactive change that impinges on a bunch of structures, which can cause anterior impingement. And then the question there is, are you going to inject, or are you going to surgically debride, or are you going to do a diagnostic injection to see if they get better and then decide whether to do a surgical procedure? Similarly, you have posterior impingement, and we see this a lot in our fast bowlers and footballers. And the idea really here is that because these guys use their foot and ankles so much, they've all suffered ankle sprains. Oftentimes, they have a prominent stiada process or an ostrigonum. And when these players have an added element of instability, or the stability of their ankle is compromised for whatever reason, then that posterior process tends to impinge more so on the FHL and produce those posterior impingement symptoms. And now that can come either from a prominent stiada process or from an ostrigonum. And sometimes you can have bony impingement of the trigonum itself, and you can see a lot of bone marrow edema. So we can see posterior impingement as a result of ankle instability. And here again, whether to inject or debride is sort of the question that helps you to answer. Last but not least, we'll talk about the sinus tarsi syndrome, where essentially you have tibiotalar instability because of an ankle sprain. And what that does is it increases the loading on your subtalar joint. And when you have increased loading on your subtalar joint, there is laxity of the subtalar ligaments, which manifests by slow laxity, which is essentially mucoid degeneration or change. And when you have that mucinous change in those ligaments, then that produces effects on the neurovascular structures that are within the sinus tarsi, and you develop a sinus tarsi syndrome. And it can manifest simply as edema within the sinus tarsi, as seen here on this coronal image, or by the formation of large cysts and a cystic change along the sinus tarsi. So we see both these changes oftentimes. So what I've tried to do in this second section is we've talked about the situation of recurrent ankle sprain, where we want to look at the ligament, we want to look at the quality of the ligament that we need to reconstruct. We want to look at the osteochondral changes, which Melanie is going to talk about next. And then we want to talk about the dynamic changes of anterior posterior impingement or sinus tarsi syndrome, which will help us to understand how to manage these conditions. So what I've tried to do in the last 15 to 20 minutes is give us all a sense of why we image an ankle sprain, what causes, why do we look at it in an acute stage? What are the reasons we're looking at it and how it helps us in management? And then we're looking at in a chronic state, what are the things that we're looking at to help us decision make in terms of managing the unstable ankle. The question on the Bassett ligament has not been answered here. The structure can be seen. To be very honest, I would say we see it very, very seldom as a true cause of impingement. And the question sort of, is that I think whenever we see impingement, we need to ask ourselves whether it is true impingement or is it impingement coming from underlying micro instability, and does it make any sense to inject these patients, get them on a stabilization program, and subsequent to that see if there's any improvement in their symptoms before proceeding along the path of a surgical debridement or a surgical procedure. So I will stop with that and be open to any questions or thoughts.
Dr. Thank you very much for a lovely talk. But there's one question from our colleague that when we see that ATFL is a continuous, but what thickness actually you take, you call it as it's a diseased or ruptured or something like that.
So this is like the $1 million question, and I have to say about this is that it is unfortunately at this stage down to eyeballing, because there's no real study that says that look, this should be the. And if we think about ankle instability, it's a dynamic process. So in other words, if you think about it, you know thousands of people who have had ankle sprains, but not all of them develop instability. And all their ligaments remodel to different ways. And the stability of the ankle is dependent upon not just the ligament, but also on the structures around it. So short answer to your question, I don't know that, how thick it is. I mean, probably 3-4 millimeters is where you would say it lies at normal. But some people will have a thicker ligament. Some people will have a thinner ligament. I think there's a lot of variation to it. And the presence and absence of instability, I think, is a dynamic process that is related to more than just the ligament itself. So a ligament can remodel and look really nice, and somebody could still be unstable. And a ligament could barely be there, and the person may not be unstable at all.
There's another question, which is a very common scenario in our day-to-day practice, that when there's a medial malleolus fracture, can we make it out whether medial malleolus is injured or deltoid is injured or not? So when you have a medial malleolus fracture.
Yes. So, I mean, that's again going back to sort of when we were talking about the deltoid. So you have here, so this is exactly the situation. You have a patient here where you have a medial malleolar bone marrow edema. And along with that, you can see that these fibers of the medial, you see this one, this is a normal triangular appearance of the deltoid with these pencil thin bands of synovium between them. Whereas when you have somebody who has this injury, you can see there's edema and disruption of those fibers. So you can definitely tell that there's distortion of the fibers. You can tell to some extent the degree of distortion as well in terms of grade 1, 2, or 3. The challenge with many ligaments, though, is that when you image them early, there's a lot of edema and you tend to overcall the injury. And when you image them later on, there is an element of remodeling, and therefore you may tend to undercall the injury. So the early imaging is great to let you know, yes, there was a deltoid injury. The late imaging may show the structure looks relatively normal, but clinically you will be feeling laxity. So you'll say medially the joint is lax. How are you saying that the deltoid looks normal? And I would tell you in that situation, yes, because it looks like the fibers or the collagen has remodeled well, but we cannot tell laxity based upon an MRI image. We can tell you the quality of the tissue, but we cannot tell you that the tissue is lax or not. That is more of a dynamic phenomenon.
That's right. But our problem is when we have a displaced medial malleolar fracture,
yes,
it is quite automatic that the length of the deltoid will decrease.
Yes.
And the architecture of the deltoid ligament change because of the displacement of the medial malleolus downwards.
Yes.
So at that time it becomes very difficult that should we plan for a medial malleolus fixation only or a medial malleolar fixation plus deltoid?
So in most situations, what you find is if the bone has given away, the ligament will not be as competent.
Yeah, most of the time it's like that, but there are.
And you can, so in those situations, you can actually look at the architecture of the ligament itself, and you can say this ligament looks more robust or healthy, whereas this ligament looks less robust or healthy, and that will give you enough information for you to take that call as to whether you should just do a medial malleolar surgery or you should also supplement it with a deltoid reconstruction.
And particularly in certain cases where we have one of the colliculus of the malleolus fractured, and the other part may carry the, you have the partially intact medial malleolus, and the other part is being taken.
Yes, so we can see that. We can see that. We can tell you that. We can tell you that the anterior half of the deltoid footprint on the medial malleolus is avulsed while the posterior half is intact. We can give you that information.
There's another question. Is there any about the sinus tarsi?
Yes.
Which I think you have covered the importance of sinus tarsi, and if it shows inflammation, what subtalar pathologies you should have in mind.
So this is what I have noticed in our practice, is that most of the time when we see that there is subtalar edema, it is most often accompanied by a tibiotalar ligamentous insufficiency. The other situation where you see it oftentimes is when you have people with flat feet, because they are also overloading their subtalar joint. You tend to see some degeneration of those ligaments. So I think those would be the two big clinical scenarios that we think of. Sometimes in an inflammatory arthropathy, you can have inflammation of the synovium in the sinus tarsi, but that tends to be sort of less common. Probably the most common effect of subtalar ligamentous involvement that we see is intraosseous cystic changes at the angle of Gissan. We see that very often in the calcaneum, on MRI, on X-rays. And most of the time, if there is not a lot of edema within the sinus tarsi, I wouldn't even make anything of it. I would just not even call it or not even make, because I see it so often. So the primary issue is basically, I think the sinus tarsi stuff is the most common thing is it is a reflection of an element of subtalar micro instability for whatever reason that has come.
The other question is from my friend Kamal Dureja. When we look at the console, it is a different experience from films issued.
Right.
So the dilemma is it not always possible to supply CDs, or just the films they don't actually give you the exact view?
Yes. So most imaging centers will give you a CD. If they are not giving you an area, you just request it. Most of the time, it's a question of when you write your request to the patient, saying get an ankle MRI done, you can just write to them, please provide CD also. So you will get a CD every time. And getting a CD in today's day and age is not really that much of a challenge. So, every center should be able to give it to you without much difficulty. And most of our centers actually give it by default.
Yeah, I think
one more question from Dr. Manu.
Yeah.
And that is, many times we have found that MRI has missed the peroneal tears. So according to you, what should be the sensitivity and the specificity of the findings?
So I'll put it another way. Many a times I find that the orthopedic surgeon didn't see anterior instability only. So the point of it is really that most of the time you do pick it up. It's there. It's just a question of somebody going back, looking at it. It's an easy area to miss because somebody may not be attuned to it. Somebody may not be thinking about it. If you have an element of what we call dynamic peroneal instability, it's a question of when you image the patient. So if you image the patient in partial dorsiflexion and that peroneal tendon is sitting in the retromalleolar groove, then you're not going to call anything on it. But if you do a dynamic ultrasound, then you can show that it is snapping. So I think here the issue is in terms of how aware your radiologist is of what you're looking for. And most of the time, if they are aware or you put a specific question, please assess for peroneal tendon pathology, then they will be able to pick it up. So the reason why this may be missed is because I think more an error of oversight than an error of not actually being there.
Okay. There's one more question from Dr. Gaurav, that is more directed towards us. He wants to find whether injecting PRP is going to help a partially torn ATFL Dr. Gaurav, I'm sorry, I don't have much experience.
So I do a fair amount of these actually.
PRP in I don't have much of experience. But if Dr. Dafri does it, then I'll very happy to know about his experience.
So we do PRP injections. We find that PRP is most helpful in tendinopathy. And I'll talk about it a little bit when we talk about posterior tibial tendinopathy in management. But essentially, if we have a degenerated tendon, but overall the tendon quality is fairly robust, then we would consider doing PRP. But if it's a very attenuated, thin, ratty, shredded tendon, then to do a PRP is probably a disservice to that patient. As far as ligamentous pathology goes, if you have a completely torn and attenuated ATFL, to go ahead and inject PRP into it makes little sense, because you're not like you want to regenerate that tissue. If you have what I showed you here, for example, this intermediate grade injury of the ATFL, where you can see thickening and edema, then there is some potential to injecting or some reason to inject a PRP into it. But overall, I think the results for a PRP into anterior talofibular ligament injuries are questionable and debatable at best. So I don't know how much it would help. And you have to also think about the outcome. Are you looking for the fact that you want to get somebody back into play faster? Or are you looking to say that this will make the ligament quality better? I don't think those questions have actually been systematically answered anyway.
There is another question from Dr. Manut. He has seen many a times bone edema in the talus after ankle sprain. So what is actually the inference from that?
So it is basically in my opinion, it is an impaction injury. And that's why I showed you this case here with the talar head bone marrow edema. So this is something that we see very often. And my suspicion is that it is just an element of impaction that happens during the inversion injury. You have a talar head impaction and you get that edema there. And I think the only thing it really signifies is that there is now an element of bone edema. And as opposed to a soft tissue injury, this may take a little bit longer to settle. And therefore, you're dealing with an injury that is probably a little bit more significant. And therefore, you would just reassure the patient that, look, it's going to take a little bit longer. The other thing that it potentially also gives you a clue to is possibly an injury to the spring ligament. Because if you think about the area that it's running under where that calcaneonavicular ligament would run. So sometimes you will have an associated spring ligament injury. And that's the other area that people have been talking about, is when you see ankle sprains, there is a greater now look at associated midfoot ligament injuries, which again, although they would be managed conservatively, are a clue to telling you or telling a patient that you need to take it easy for longer before you go back to activities.
So I may like to add that in these fractures, sometimes you have a midfoot sprains,
yes,
where you have a adduction sort of forces, which actually lead to tension, the ruptures on the lateral side, and then you can have impactions on the medial side. So I would suggest if you are seeing something like this, you should have a look at the midfoot also on the lateral side, if you want to see some avulsion fracture or something like that, where you can have avulsions on the lateral side and the impactions on the medial side.
Yep.
So I think we can go ahead with the next talk.
Okay. All right. So let me end my show. And
there's one small question. Instead of the head, if you have edema in the talar body, what is its significance?
So we have normally the two areas that we see edema in are the talar head at the talar dome. The talar dome is the impaction injuries that happen, which Dr. Melanie will talk about, which are the more common injuries which happen because of the loading. The talar head I've seen very often. The talar neck bone marrow edema, I think when you see it, there are two things you have to think of. One is whether it's actually traumatic edema, or two is if you see sinus tarsi degeneration and cystic change, you can see bone marrow edema associated with that. So that's what you need to look for. And then seldom you can see a talar neck fracture, but that's usually pretty obvious.
Okay, and we can go ahead with the next talk.
So now I'm going to talk about osteochondral lesions of talus, and this is a very short, about 5 minutes or so. Over the next about 5 minutes, we'll talk about osteochondral lesions of talus. So as we all know, they are more common anterolateral and posteromedial talar dome. And in our practice, we almost always see them following injury. It is post-traumatic, and then there is chronic instability, and we are looking for these osteochondral lesions. And the whole idea of imaging is to try to help in guiding you for the treatment. Radiographs can show these lesions, but about 1/3 of the lesions may not be seen on the radiograph at all. So MR would help you pick them up at a much earlier stage when you're not yet seeing the fragment, or when it's not seen as a defect in the medial talar dome as it can be seen here. But for this, very important to have high resolution imaging. So I think, so again, as I said, whether it's 1.5 Tesla or 3 Tesla, more important is to get low field of view. The field of view to image should be kept small, say about 14 centimeter, 12 centimeter, whatever is needed for the ankle. So that's another thing, because most of the time the requisition would say many a times ankle and foot. But what we need to understand is an ankle scan is an ankle scan and a foot scan is a foot scan. You cannot do both of them together. Again, hind foot, mid foot is a separate scan, forefoot is a separate scan. If we try to include everything in one study, the resolution is lost. And once there is no spatial resolution, you can take a whole foot scan and then just zoom and print it to a particular area, but there's no resolution for us to image these things. So it's very important that we are clear what we are looking for. So we may start off with one stir sequence, sagittal stir, including both ankle and foot. But after that, the scan has to be targeted to either only the forefoot or the mid and hind foot or the ankle, because specifically the area we need. Otherwise, the scan is not of much use to look for finer details. So it's very important to look at the cartilage. So like I said, here you can see the cartilage extremely well. And for ankle, it's all the more important to get these high resolution images because the cartilage is so thin. Unlike knee or shoulder where the cartilage is thicker, here the cartilage is so thin that we need these kind of high resolution proton density image which can show us the cartilage. So the role of MRI is one, the size of the lesion can be accurately given, the location of the lesion so that you can, in case you plan to do a surgery, you know how to approach it. What is happening to the articular cartilage? Is it intact? Is there fissuring? Is there delamination? Is there cartilage loss? Are the articular surfaces congruent, or is there cortical depression? Is there more diffuse osteoarthrosis? And also the bone fragment which is there. Has it become necrotic? Where is it located? That is the role of MR. So it's important that we describe the lesion, the site, whether it's in the anterior segment or in the posterior segment of the talar dome. Again, within this segment, is it in the anterior portion of the posterior segment? Because obviously this will help you in planning the surgery so that the exact location is known. And the classification that we follow is the Anderson's classification on MRI. The stage 1 is where the cartilage is intact. You just have a subchondral compression. So on MR, we see this just as marrow edema. So obviously this will not be seen on a CT. This will not be seen on a radiograph. Stage 2A is when you start seeing a subchondral cyst. The overlying cartilage could still be intact. 2B is when the fragment is partially detached. Stage 3 is when the fragment is completely detached but still located in situ in the talar dome. And stage 4 when it is completely separated and may be seen as the body, as a loose body. We don't, in our reports, we don't use this staging, but we describe each of this because not everyone may be familiar with the particular staging that we are using. So we'll say that there is subchondral marrow edema, subchondral cystic changes, but this is what it corresponds to, and we can always talk about these stages. So this is how a stage 1 osteochondral lesion will look. the cartilage is intact, and all you see is subchondral marrow edema. So in the acute stage, this would be because of trabecular microfractures, or it could be because of trabecular compression, which would lead to this marrow edema looking bright on the stir or the fat saturated T2 weighted image. Here you can see the fragment is completely separated, but this fragment is located in the talar dome, and you can see that there is significant marrow edema. Here what we can see is there are subchondral cystic lesion, cystic areas with marrow edema, and you can see this overlying cartilage, there is loss. So if you can look at this hyaline cartilage as this thin gray area, as you come here, you can see the tibial cartilage is intact, but this talar dome cartilage is completely, there is cartilage loss at this location. Here's another patient where you can see subchondral cystic changes in the medial talar dome. And now we can see a little bit of cortical depression. And again, the cartilage here is lost. You can see this gray cartilage intact. But as you come here, you can see this cartilage is lost. And in this patient, there is remodeling of the anterior talofibular ligament. Again, the remodeling doesn't look very good, but whether it's lax or not is not what MR can tell you. So it's important to say whether it's in the anterior segment or in the posterior segment and give the dimensions of these lesions. Here, another case where you can see a separated osteochondral fragment, but it's separated only posteriorly here. So how do we make out whether this is stable or not? If we see fluid signal intensity tracking down, then we know that this portion is separated. While here it's not separated, it's partially separated. Some people believe in doing arthrograms to look whether the injected contrast is going into this. We don't really do arthrograms anymore. And what we can see, this fluid signal intensity going there would tell us that yes, it is detached at this particular location. Here again, we can see this medial talar dome, you have a separated. So here you can, if you look at it, you feel that this portion can be lifted off. So you can see the fluid tracking in this location. So this is not a stable lesion. This is separated, but still located in that location. And here the size, it's involving almost the entire talar dome and again completely separated this location. You can see this fluid intensity going all the way inferiorly here. This was a patient who was treated with curettage and debridement for an osteochondral lesion, and this is on follow-up after about 6 to 8 months. I think the patient still had pain. So immediately post surgery, there could still be marrow edema, but later for longer, if you still get marrow edema, that would be the cause of pain. And you can still see the cystic areas here and this marrow edema, which could be the pain generator. And we can see this cartilage is a bit thinned out here. CT could show you the fragment, but it does not show you the marrow edema. So we don't really do CT for these. MR would be the best modality because it can tell you the early stages also and look at the marrow edema very well. Also, MR can at the same time evaluate the ligaments, sinus tarsi, and all of the other. Few other things which we need to look at when we are looking at these osteochondral lesions. So here this patient also has advanced posterior subtalar OA. So the posterior talocalcaneal joint can be evaluated very well. You can see there is complete loss of cartilage, subchondral cystic changes, marrow edema, and that can help whether you need to do fuse this joint, arthrodesis needs to be done. Few other differential diagnoses when you see a lesion in the talar dome. Here is a patient who has avascular necrosis. So usually we see them post-trauma. Very rarely have we seen them in patients who've taken steroids for some other condition like SLE or something. So here you have got this large area, geographic looking curvilinear area involving the medial talus. So this is not subchondral cystic change. It's much more extensive than that. And you can see this double line sign, bright line and a dark line. So this suggests this is avascular necrosis. But the overlying cartilage is intact. There is no collapse as of now. We also see subchondral insufficiency fractures. So you have disproportionate marrow edema. I have a lot of marrow edema here, nothing in the tibial side. So I know it's not an infection. If it was infection, I would expect marrow edema here also. This is reactive joint effusion. And when I look very carefully in that marrow edema, can you see this little subtle hypointensity subchondral. So that's subchondral insufficiency fracture. This is what was earlier termed as transient osteoporosis, because the resolution of MRI was not good enough to pick up this small subchondral insufficiency fracture. It was just seen as osteopenia on X-ray, called as regional migratory osteoporosis or transient osteoporosis. But now with the current resolution, we can show that there is a subtle subchondral insufficiency fracture out here. This was a patient who had an insufficiency fracture, but something which progressed. There's a large subchondral insufficiency fracture. You can see collapse of the talar dome, and you can see a defect out here in the cortex. And this would invariably lead to osteoarthrosis. So just again, a quick recap. We always need to look for osteochondral lesions, size, location, medial, lateral, anterior, posterior. What is happening to the overlying articular cartilage? Intact, frayed, fissure, delamination, loss, articular surfaces, whether they are congruent or there is any collapse, and that bone fragment. So if we look at this particular bone fragment, if it becomes dark on all the sequences, if it starts looking dark on sequence like T1, then we know that it's undergoing sclerosis, and that would suggest necrosis, osteonecrosis of that particular fragment. So MR could provide all this information as well as look at the ligament, tendons, and other structures at the same time. Any questions? I would be happy to answer.
Thank you, Dr. Melanie, for this wonderful talk. I think as an orthopedic surgeons, we are more interested in the size of the lesion when we are making the decision about ACIs or marrow stimulation techniques. So there's one question that which is the best modality for determining the size, whether it's an MRI or CT?
So MRI and CT both would be equally good to show size of the osteochondral fragment. But as I said, MRI will be able to show all these other findings like marrow edema, the ligaments, everything else also. Both MRI and CT would give the measurements equally accurately. There would not be any problem. So like I showed in the, we need to use the non-fat saturated sequence to give the measurement.
So, so basically we don't need much of CT when we need it.
Yeah, just for measurement, I don't think you would require. MR can give you the measurement accurately.
So there's another question. When we are...
Sorry, I just wanted to say about CT. The thing is that the reason you end up doing a CT most often is because the reason you end up doing a CT most often is because orthopedic surgeons feel very comfortable when they see pieces of bone, and CT shows you pieces of bone very clearly. And then the other option is that you can reconstruct CT data and show it as 3D reconstructed images, which are easy for an orthopedic surgeon to visualize. And if you go in today's day and age, you can actually create 3D models. So if you wanted to test your surgery, you wanted to see, you could actually do all this stuff, which CT will give you. You can do some of this with MR also, but it's probably a bit easier to do it with CT. So therefore, that is probably the role that CT plays in a bigger way in these situations in terms of just how people visualize things. For us, it doesn't make a difference. We're equally comfortable seeing both.
There's another question, whether we should ask for a foot MRI or an ankle MRI in posterior tibial tendon deficiency, when you have quite a lot of things going on, spring ligament, posterior tibial tendon, then maybe some deltoid, stretching, ankle going into valgus. So what normally would you suggest?
You should ask for an ankle MRI, because when we do ankle MRI, we are including the tibiotalar joint, the subtalar joints, the hind foot, as well as the midfoot, all the tarsal bones and basis of the metatarsal. A normal ankle MRI will include basis of metatarsals and everything behind. So when you're looking for tibialis posterior tendon, you should ask for ankle. If you are looking for either midfoot or forefoot pathologies, that is when you should ask for a foot scan. Because what happens, since as in we do dedicated musculoskeletal imaging, our protocols are very clearly set, but everywhere it may not be possible. So if it's written ankle and foot, and because the requisition says it, the technician will make sure that everything from tip of the great toe to the tip of the calcaneum posteriorly is included, just because the requisition says it. So I think if you can always say ankle with foot screening, if you also want us to look for something in the foot. But where the pain is, so for a tibialis posterior tendon, ankle is good enough.
Another question, how you distinguish between a large OCD and an AVN? You know, it's a very big, large OCD or AVN.
So AVN usually, as I showed you, shows that more of a curvilinear geographic-like pattern with that double line sign kind of appearance, as compared to an osteochondral lesion, which is just located subchondral and there would be cartilage abnormality. So usually it's not a problem, and we see osteochondral lesions much more commonly than we would see avascular necrosis. Avascular necrosis would have much more of a geographic curvilinear kind of pattern.
So this is one question from my side, that when we are seeing a lateral ligament injuries, sometimes you find an OCD on that. So how you are sure whether actually this is an active OCD, because that OCD may be there for quite a long time, whether it's an active OCD which is to be taken care of, or it is just an incidental finding, or in the other way, how you actually make it out, how this is an active, it should be treated or not.
Yeah. So if it's causing pain, there would be marrow edema around it. When we see marrow edema, we will describe it as an osteochondral lesion with the marrow edema, which is causing the pain there. If it is, but even sometimes in chronic conditions also, even if there's no marrow edema, but it could have got separated. The overlying cartilage could have got lost, and that itself could be a pain generator leading to joint effusion. So I think marrow edema would be an important thing to look for to say that yes, it is causing pain. And also in all ankle sprain chronic instability patients, we look at the osteochondral lesions because that could be an added pain positive factor.
So one very interesting question from Dr. Rajiv Shah, the father figure from, is there any correlation between riding a bicycle and doing MSK radiology, the musculoskeletal? it is specified to Daftari.
Very important.
So he cycles, so I'm sure there it's directly proportional. I used to cycle, now I don't much, but I also have a cycle here, right behind me, standing vertically. So maybe there's some relation.
Anyway, we can move ahead to another talk, I think. There's one more question. Dynamic contrast MRI better than for AVN? Dynamic contrast MRI.
Okay. So dynamic contrast MRI helps in looking at perfusion of the particular fragment. So ideally, yes, in ideal situation, we look at perfusion of that bone, how it is taking up the contrast. But having said that, for talus AVN, we don't usually need to give contrast. We are able to make out avascular necrosis. Diagnosis itself is not a problem. But yes, we use it more often in scaphoid fracture AVN. So with that, if you're specifically and even that could have some plus and minus because it can show enhancement on dynamic contrast, but still be necrosed. So it's not absolute, but yes, compared to plain MR, it would be slightly better. Yes.
So I think the question in these situations is sort of how viable is the piece of bone within the osteochondral lesion? And you're trying to look at different ways to see if it's viable. Obviously, if it looks very sclerotic on CT, your tendency is to say that this is not going to be viable, it's dead bone. If on the other hand, you see some edema on the CT, you say, yeah, it's edematous. And that perfusion or that contrast enhanced image gives you one more level of confidence that, yeah, there is some flow in this bone at least. So if I fix it, then there's at least some chance that it will come back, as opposed to there is no flow in this bone. Jane do, let's just take it out and maybe we'll bone graft or we'll just leave it as it is.
Any role of SPECT CT in OCD?
So there are articles which talk of it. They have compared MRI and SPECT CT. Saying that on SPECT CT, if there is an uptake, that would be also would be very reliable. But frankly, for ankle, we don't really use it. SPECT CT, we would use it for, say, stress fractures in the spine or osteoma, those kind of situations. In ankle, most of the times on the routine imaging, we are able to give the information of the routine MR well enough.
So how often you see your ligaments, lateral ligament or the ligaments attenuation in the presence of OCD?
All the time. So as I said, whenever we see osteochondral lesion of the talus, almost always it's in a way post-traumatic and the ligaments do not look normal.
So I think we can go ahead with the next talk.
All right. So I guess this is something that somebody has been asking about. This is what this talk is about MRI in the imaging of flat foot. Here, essentially, I think what we are looking at when we look at a flat foot patient is we want to know what is the cause of the flat foot, and we want to know what are the effects of flat foot. So there are essentially two reasons for which we are doing the for which we are doing. Sorry, let me just get this. So two reasons in which we are scanning. When we are looking at the etiology, we're trying to determine if it's primary, if it's a developmental cause, or if it's an acquired cause. And then in the effects of a flat foot, the effects generally tend to manifest upon the posterior tibial tendon, because whenever there is a flat foot, automatically the dynamic stabilizer of the arch becomes more activated, which is the posterior tibial tendon, and that tends to have pathology, which can manifest as tendinosis, synovitis, and then there's a role of the accessory navicular in terms of the management. We'll talk about that. And then while you have one side of the joint sort of collapsing, the opposite side is compressing, and so you'll see subfibular impingement, and then you can see cartilage changes. So if we think about the etiology of flat foot, you'll see there's a primary heel valgus, and that is obviously assessed clinically as to whether you have a flexible or a rigid flat foot. You have developmental conditions like coalitions, and then you have acquired, not coalitions, but acquired conditions actually that can do that. So this shouldn't be, it's just acquired causes for it. The X-ray is usually a good way to look at, weight-bearing X-ray is usually a good way to assess for primary heel valgus versus even developmental conditions like coalitions. Except some coalitions are missed easily on radiographs, again, because one is not attentive to what they are, and the findings can be somewhat subtle at times. So an MRI or CT plays an excellent role in terms of confirming that you have a cause for a rigid flat foot. And then when you think about the acquired and the effects, then MRI and ultrasound play a larger role in terms of understanding what the effects of the flat foot are. So the first sort of thing that comes up is, how do you identify a flat foot? And usually it's identified on a weight-bearing radiograph. But on an MR, what I have found and what we have found in our practice is we pay attention to this tibiocalcaneal angulation, okay? And you can see across the spectrum of cases how that tibiocalcaneal angulation sort of increases. And when you see that increased tibiocalcaneal angulation, I find on the coronal image, I find that is a good indicator for somebody whether they have flat foot. So you know that this side there is subfibular impingement, this side there is collapse of the arch. So this is sort of my first clue when I'm looking at these, even though it's not weight bearing, to make that call that I'm probably dealing with somebody with a flat foot, and therefore I'm going to start looking for the pathology of events that goes with a flat foot. Once you've identified a flat foot, the first thing to do is to start looking for coalitions. In our country, we don't have coalitions anymore because we have a single party type situation now. But in places where we used to in our past, we had coalitions, so we looked out for them a lot. And the places to look for them are typically along the anterior aspect of the calcaneum and at the junction with the navicular. So that is your calcaneo-navicular coalition in this location. And what you typically see is, if you look at the normal margins of bone, they are fairly sharp like this and sharp like this. But in the case of a coalition, what you'll see is there's flattening and there's this little irregularity here. And this appearance really is the one that clues you in that this is a coalition here. Sometimes you will see bone edema around this area, which is another clue that says. So I would look on the sagittal images at the anterior process of the calcaneum for a look for a calcaneo-navicular coalition. The other common coalition that we see is the talocalcaneal coalition, which typically happens at the level of the sustentaculum. And here you can see I've shown you a normal sustentaculum here. And what you can see here is this is the normal flat appearance of the sustentaculum. And you can see the double black line over here, or the single black line, and this is pretty normal. Whereas here you can see that there is some fusion across this line, and this is typical. The other findings that you can see in this are, instead of it being horizontal, it tends to be sort of at an oblique angle like this. And so when you see that there is some obliquity to that sustentacular joint, that's another reason for you to start thinking about a coalition. So two common areas that you look for coalition are the anterior process of the calcaneum and along the sustentaculum. So these are two areas. Anytime you see anybody with coalition, that's what you should look for. Now, when you have somebody who has a flat foot, obviously you have usually a situation of a heel valgus. So the talar head becomes unsupported and starts to dip down. And when that talar head starts to dip down, then its natural tendency is to create a stretch upon this whole complex of the tibial spring ligament, which includes the tibiospring ligament here and its extension down here, which is the calcaneonavicular ligament. And you can see here how this ligament is actually a fairly slender structure. So the tibial spring ligament is fairly robust, but the calcaneonavicular ligament is fairly slender and attenuated and variable in appearance. And with someone with a flat foot here, what you can see is that that ligament has become quite thick and edematous. So while it is a hard thing to see and a hard thing to call, and it takes some getting used to looking at it, this is the area where you would look at it on the coronal images to look to see if there's any added loading, thickening abnormality of the calcaneonavicular ligament in a patient who has flat foot. So here again, just a zoomed up image for you to see. You can see the normal calcaneonavicular ligament here. Sorry, this arrow should be green actually, and this area should be red. But here you can see the abnormal ligament over here. So this part of the ligament here is all abnormal. Okay, so this is an abnormal tibial spring ligament and calcaneonavicular ligament. The third effect that you see in patients who have a flat foot is that as this heel goes more and more into valgus, you have narrowing of the subfibular space. And when you have narrowing of that subfibular space, you have impingement of the traversing structures. So sometimes you can have narrowing of this subfibular space. And here what you can see is the peroneal tendon is running outside. So even though there is subfibular contact, you may even see edema and abutment of these two structures. The peroneal tendon is actually spared in this situation and it's not involved. As opposed to this case here, where you may have a prominent peroneal tubercle along with an inferior tip of the lateral malleolus, and you have crushing of the peroneal tendons as they traverse in this area. So subfibular impingement is the third entity that you will see in patients with with flat foot. And those are the appearances of it. Now, this brings us to probably the last but the most important aspect of somebody who has a flat foot, and that ends up being posterior tibial tendon abnormalities. So the posterior tibial tendon, as Melanie showed you, runs along the medial compartment as the anterior most tendon. You can see it very nicely on a sagittal image as this band of tissue that's running like this and connecting to the medial process of the navicular. So it's a really nicely seen structure like this. Now, when you look at it on the axial images, you can see it's oval, it's black, it's sort of homogeneous. And here you can see, there's a split inside this, okay? You can also see that the split is not at the insertion. The insertion is down here and the split is high up. So this is a non-insertional posterior tibial tendon split. You can actually even measure the length of the split and say it measures this long, extends this long, and give you those characteristics. This, on the other hand, is someone where you can see that there's involvement very close to the bony attachment, and therefore this is insertional posterior tibial tendinosis. And the importance probably of the two is that something that is insertional has a greater likelihood of giving way if it is involving a larger portion of the bone, as well as something that is non-insertional may have lesser likelihood of giving way ultimately. You can have an insertional tendinopathy, and along with that, what you can have is basically here you have a connovate or a prominent medial process of the navicular, and therefore you see bone marrow edema in that as well. So you can have tendinopathy with bone marrow edema, and we'll talk about why this is important. And then you can have situations where you have an accessory navicular bone, which can have an abnormality, which may or may not have edema along it. And then last but not least, you'll have a situation where you can have just tendon sheath fluid along that posterior tibial tendon. So these are all the potential abnormalities that you could see with the posterior tibial tendon. And this becomes important in terms of your management. Just to show you a case here of somebody who's had a posterior tibial tendon rupture, You can show them that, the tendon is torn. This is where the proximal end is. This is where the distal end is. So somebody can be given an idea of how big the gap is, whether they'll have to reconstruct it, whether the tendon quality is good. And we can give you all that information in terms of what to do next. Now, what is the potential role of imaging in managing posterior tibial tendinopathy? So you have three components of posterior tibial tendinopathy. You have the bone and the accessory navicular. You have the tendon and you have the tendon sheath. So if you were to look at the bone, you would have changes that could be normal. You could have bone marrow edema. You could have an accessory navicular without edema, and you could have an accessory navicular with edema. And here the primary issue is when you have bone marrow edema, you realize that you are dealing with a situation where bone is involved and where no amount of injections are going to really do anything, because an injection, whether of steroid or PRP or whatever else, is not going to have a short-term role in reducing bone swelling. Bone swelling is going to take time to resolve. So if you were to inject a patient who has bone marrow edema, then you have to tell them that, look, this may produce some reduction in your symptoms because of the tendinopathy or because of the synovial inflammation, but the pain from the bone is going to take some time to resolve. On the other hand, you have somebody with tendinopathy. You're thinking about tendinopathy, as we said, with insertional or non-insertional tendinopathy. And here you're looking at the tendon to say, is this robust tendon? Is it just tendinosis? Is it a partial tear or split? If that partial tear or split exists, what percentage of the tendon is it involving? Is it near complete or complete? And if you're dealing with a tendon that looks rather robust, otherwise it looks thick, then you would say that, look, this is at least relatively healthy appearing tendon. If I inject steroid, I can tell the patient to sort of take a step back. If I inject PRP, I can tell them to take a step back. But overall, I'm not at that situation where the tendon is already at a breaking point and my intervention is going to make things worse. If you have a tendon that looks very attenuated or is sort of borderline, even that 50% range, and somebody has excruciating pain and you're going to do something for them, you can tell them that, listen, I'm going to do something for you, but it is very important that you be very, very conservative with what you do with this tendon, because you are more likely to rupture. Or you may say, let's not do anything. Or you may say, look, you are anyways more likely to rupture. Let's just do surgery now. Or look, it'll rupture and we'll operate on it then. So the quality of the tendon, the robustness of the tendon is important in terms of determining your management plan as to what you do. Last but not least, when we talk about the tendon sheath, we talk about the presence or absence of fluid. We can see the presence or absence of synovitis, and we can see whether we're dealing with primarily a synovial issue or if the tendon is also involved. So if it is just fluid or a synovitis with a relatively normal tendon, in our practice, one tends to inject if there's a lot of pain, or just use sort of some rehabilitative methods like a foot support arch or whatever else to try and reduce that inflammation. But on the other hand, if you have a tendon involvement as well, then you're going to deal with it more like a tendinopathy than a synovial problem. So MRI, I think, provides you with a lot of insight in terms of how you can approach somebody with tendinopathy and how you can think about managing them and how you can explain to them what kind of outcomes you're expecting in this situation. So what I've tried to do in these last 10 minutes is sort of identify flat foot clinically and also on the coronal MRI to determine the etiology. We've given you some clues of how you can identify coalitions. We've talked about subfibular impingement and the spring ligament. And then we've talked about posterior tibial tendinopathy and how MR can help you to guide your management strategies when it comes to posterior tibial tendinopathy. So I'll stop right there then.
So, Dr. Zafri, can you hear me?
Yes.
Yeah, there's a question from Dr. Rajiv Shah once again.
Yeah.
When you would like to use both MRI and ultrasound?
So I find that when I am dealing with a situation where I have any concern that there is bone involvement, then I find MRI is important. So for example, if you had a patient with posterior tibial tendinopathy and an accessory navicular, then you may want to use an MRI to say, look, is there edema in the accessory navicular? Especially if you're considering intervening, you're saying, okay, you have posterior tibial tendinopathy. We want to do a PRP for your posterior tibial tendinopathy. We're going to inject you. And at that stage, you want to tell the patient that, look, we want to make sure that when we inject you, that you're primarily a tendinopathy patient and not a bone pain patient. So, we have that sort of differentiation. So those are the situations in which I would say, or if you have a situation where you have a known accessory navicular and you're trying to determine whether this is accessory navicular stress reaction or this is posterior tibial tendinopathy, there I think you would find it very, very useful to use an MRI along with the ultrasound.
Another question, how do you avoid a magical effect during MR screening?
So
again, by Dr. Rajiv Shah.
Yeah, so magic angle effect is what Melanie talked about earlier, is basically related to the angle of a structure to the MRI z-axis. So in other words, the long axis of the magnet and the angle of the foot. So you change that by changing the angulation of the foot. But more importantly, a magic angle effect will typically come in a given plane. So if you think that a tendon looks abnormal in, say, the axial plane or the coronal plane, then look at the other plane. So look at the coronal and the sagittal, and if the structure looks normal in those planes, then it's probably a magic angle effect.
There's a question from Dr. Rajesh Simon. What are the findings which actually help tell us that PRP is going to work in this posterior tibial tendon dysfunction or not?
So so the first thing is, do you believe in PRP? This is the biggest question.
I don't believe it.
No. I'm just saying in terms of anybody who's using PRP.
I don't believe it.
So the first.
I burned my fingers.
So the first question is, do you believe in it? Now, if you do believe in it, as I said, the times that we believe in using PRP, definitely in the foot and ankle, there is a greater enthusiasm and probably better outcomes with foot and ankle using PRP, especially for posterior tibial tendinopathy, Achilles tendinopathy, and plantar fascia. These are at least 3 areas that we've seen good results. The times, because what you're doing with a PRP usually is you are trying to produce micro trauma within a tendon, and then you are trying to apply a catalyst. So it's like a 1 step back, 2 steps forward phenomenon. Yeah. Sorry. There's a 1 step back, 2 steps forward phenomenon they're trying to do. And so you are going to produce some damage to the tendon. So if you find that is a thin and attenuated tendon, then I would not do it. But if overall I find it's a regularly thick and robust tendon, then I will end up doing, then I will be more likely to do a PRP.
There's one question on tarsal collision, which is directed to me, you, as well as Dr. Ajoy. So I think both of 3 of us have to give the comment on this, that in talocalcaneal collision, when you have a valgus and an impingement, how you decide whether you go ahead with a conservative or a surgical treatment? Maybe if MRI helps something in this.
So I think that from the standpoint of what we would tell you on an MR is, we would tell you whether or not there is a coalition. We can tell you how thick the coalition bar is, whether it's completely bony, whether it's osteocartilaginous or purely a soft tissue coalition. And we can give you a sense of the morphology, in other words, the size of the coalition itself. Now, in terms of whether you want to intervene on that coalition or whether you want to do something about it, I'm not sure what specific symptomatology you look at when you decide to make that call. But if you decide to make that call, I can definitely tell you, look, this is the amount of bone that you're going to have to open up. This is the area that you're going to have to clean up. This is the area that is abnormal. I can give you that morphologic information quite comfortably.
So the other thing is, what I add to this is that sometimes you have the stress on these coalitions.
Yes.
You know, because of the injury, because of this. So it can coalitions are present for years and years, and they actually become symptomatic in adolescent. So probably the dilemma in the person who's asking the question is, I think pain is one more important, and can we pick it up whether there's some stress going on in these so how we can look into that?
Yeah, so when we're looking at coalitions, as I mentioned earlier, it's not uncommon for us to see edema in the bone at the level of the coalition. Another thing that sometimes we see associated with the coalition is a small little adjacent cyst. So that coalition, because it's got like a little bit of a pseudoarthrosis there, it also produces a small cyst adjacent to it. So sometimes we're not, and we've had a few patients where there's a cyst and we end up puncturing that cyst, and that gives them some temporary relief of their primary symptoms. So you're right, in terms of there being a coalition, there being bone edema, and there being a cyst, and that coalition already being there since birth. The question is, do you say, okay, look, you may have stressed it somehow, let's just wait, let it resolve, or you have a small cyst, let's just puncture that, see if that resolves your symptoms before you decide on a surgical alternative. I suppose that's another option that's available.
Dr. Jai, would you like to add something on this?
Yes. The bony coalitions generally are not very symptomatic with regard to the coalition itself. They don't have too much of pain or anything with that. But the ligamentous or the fibrous coalitions are the ones who generally complain at site of pain at the coalition itself. I think they are the ones which we should be addressing surgically whenever we're dealing with them. And the secondary effects of a coalition, the talocalcaneal coalition, I think one of the telltale signs can be seen on an X-ray itself. The kind that we see with an anterior impingement of the talus, we see like almost like a rhinoceros horn there. So that itself would show us that there is a coalition, and we might not need to go in for anything further beyond that, any investigations. With regard to the management, I think what Dr. Aditya has already told us, with presence or absence of edema, that would probably dilate us more rather than anything else.
What I feel about coalitions is what is the degree of the valgus which is associated with the talocalcaneal coalitions. So if it is really quite a lot of, let's 16 degree in one of the papers, the valgus was shown, which can cause lots of the your impingement on the lateral side, and it can cause stretching on the medial side. Usually the patient is walking on the valgus. So when the patients have complaints due to this, then you have to go for surgery. Then coming to, there was another question, whether fusion or the excision of the coalition. When you are ready, if you are having more than 50%, most of the time it's already fused. So it is basically the fusion. But when you are doing the excision, you should be very particular that you are able to get the movement at the subtalar joint. If you leave that and you have done the partial you sort of excision, then you have not done the job. And then thirdly, you should not forget that you have to realign everything, the axis. So even with fusion and without, even without fusion, if there is more of valgus, you may have to correct it by a calcaneal osteotomy. So that is, I think I have answered the question on that. And now we have some more questions. One is from Kamal Dureja. He says how you can be certain that accompanying arthritis of the subtalar or talonavicular joint is contributing to painful gait. So can can we get to know what are the pain generators in posterior tibial tendon deficiency from MRIs? So,
yes. So, I mean, I think first of all, in terms of what I was trying to show you earlier on my talk was all those different pathologies that you can see of the posterior tibial tendon. They are all clues to what could be potential pain generators. And obviously the second level which you go up, and when you're talking about the subtalar joint, whether or not there's cartilage wear, we can see the cartilage well, whether or not there is subtalar bone marrow edema. So bone marrow edema generally is a slight indicator of pain. The third thing is when you do ultrasound, I can see vascularity, you see neovascularity, you see blood flow and Doppler within the tendon sheath, then that's another common indicator of pain. So these are diagnostic imaging signs of pain generators. Bone marrow edema, neovascularity, these would be the two big things that would, and synovitis would be the things that would indicate potential bone generation capacity or capability. The proof of the pie tends to be the pudding. So you end up saying, do you do a diagnostic injection into that focal area? And in that case, do a ultrasound guided injection so that you are sure that you are exactly in that space, which is the potential pain generator, to confirm your diagnosis. So whether it be saying, I want to make sure I inject into the subtalar joint and the subtalar joint alone, I want to do a small volume injection to make sure that it's just sort of in the place that I want it to be, and then confirm that there's symptomatic improvement. I think that's sort of where imaging comes into play in these situations.
There's one other question which I don't understand, but the question says, I did not understand how synovial fluid could be around the tip post.
So there is a tendon sheath that surrounds the tip post tendon. It has got synovial lining, and that synovial lining oftentimes gets inflamed or irritated, and as a result of which it produces more synovial fluid, which then tracks around the tendon. So you may see that as just simple fluid. There's also an element of tracking of intra-articular fluid that communicates a little bit with the posterior tibial tendon. It's more with the FHL than with the PTT, but you can see intra-articular communication with the posterior tibial tendon. So that's how you can get some fluid, but you can also get a primary synovitis because the synovial lining of the tendon sheath is inflamed.
I think I have one more question. When do we decide to do a weight-bearing X-ray to rule out hindfoot valgus, even if we don't see it in an MRI?
You wouldn't see it on MRI. MR is not a weight-bearing study. So whenever you have a concern for hindfoot valgus, which should typically be if you see pes planus, then you want to get a weight-bearing radiograph to look at it and look at the alignment and figure things out. So I think in terms of looking at osseous alignment with weight-bearing, radiographs are still your way to go.
So I think there's one more question between a cartogram and cartilage, plain MRI versus cartogram.
So this is a good question because most orthopedics, so this is a situation which radiologists have marketed extremely well, where we have said you must do a cartogram. And this is a sequence that is marketed by GE as well as Siemens. And unfortunately, radiology practices have paid money to buy these sequences. And therefore, we have had no choice but to tell you that, look, this is available and you should use it. The truth of the matter really is a cartogram is a sequence that allows you to look at cartilage, but by the way it works, it applies a color scale. So it essentially makes it look very pretty for you in terms of, dekho, this is green cartilage, this is blue cartilage. This means this cartilage has got better quality than the others. But when you are looking at cartilage itself on a proton density image, and if I may even just share any of the slides that I had earlier. Where did that go? Oh, this is not my, I don't think this is my PowerPoint. But I mean, okay, yeah. Can you see this by any chance?
No,
not yet.
Need to start screen share.
Okay, let me do that. Okay, can you guys see this now?
Yeah.
Okay.
Yeah.
So if you look at sort of any of, let me just see this. Any of these images here, if you look at this image here, this one on the left, you can see this gray area here just above this. This is essentially the cartilage, this gray lining. So if you zoom that up, you can see the cartilage really nicely. You can see it even better on 3 Tesla images. You can tell chondral lesion. So my question to you when you ask for a cartogram is, if you are trying to determine, look, is there OA, is there bad cartilage loss, you do not need a cartogram. You need a cartogram if you're trying to say, okay, I just did an Oates procedure on this patient and I want to know the quality of the cartilage in that Oates procedure region. Then a cartogram is a good way for you to tell whether that is being taken over by fibrocartilage or hyaline cartilage. There one might consider a cartogram, even though I can give you that information on a regular study. You don't need to do a cartogram for that. So the cartogram is a very specific study which has got a very, in today's day and age, a relatively small indication to use. So I would say for the most part, most of the cartilage lesions we need to see, most of the decision making you need to do can come from a well done 3 Tesla or 1.5 Tesla MRI that can give you all the information you need.
There was another question on the stress and coalition we have already discussed. So we can go ahead with the next talk. I think probably the last talk.
Okay, so we'll pass it over to, let me stop sharing and hand it over to Ankita.
Is my screen visible?
Yeah. Yes, absolutely.
Yeah, thank you. So now we would be discussing in next 15-20 minutes about the Lisfranc ligament and the midfoot injuries. So what are we trying to focus on? The anatomy of the Lisfranc ligament, the mechanism of injury, and what all imaging we do and how will it impact your management. So let's start with anatomy. We all are aware that it's a complex joint and it has a skeletal as well as capsulo-ligamentous component. So let's just start seeing. So osseous component. So if we are dealing with midfoot, all our cuneiforms, cuboid, and all the metatarsal bases together, this will make your midfoot predominantly. And out of this, your second metatarsal base. So this area is the keystone. This is the area which provides the maximum stability amongst the osseous structures. Why? That you can see very well on the MR as well. So this is your first metatarsal, second, third. Somebody was asking. So if you see sequentially on axial and coronal images, you will be very clearly able to identify the metatarsals. So this is your first, second, and third metatarsal, and these are your cuneiform bones. And you can identify really very well how your second metatarsal base is placed between your two cuneiforms. So this lock and key system of arrangement provides a very good stability to the midfoot joint. Then the midfoot joint is divided into 3 columns on the basis of stability. So this is your first column, which is the first metatarsal and the cuneiform. This is your second column, that is the middle column, which includes the second and third metatarsals and the middle and lateral cuneiforms. And your lateral column is composed of fourth and fifth metatarsal bases. So what is the importance of these columns? The lateral column is a little less rigid as compared to the other 2 columns. The rigidity of other 2 columns provides stability, but also is prone. That's why those areas are more prone to injuries as compared to this one, because this helps you resist the injuries. Now coming on, so we have till now seen the osseous part of the Lisfranc or the midfoot. Now coming on to the capsulo-ligamentous part. So if we want to see the capsulo-ligamentous part, the modality which we need to use is MRI. Osseous part can be seen on bone, but a lot of details like marrow edema will be added on by the MRI. But the capsulo-ligamentous part of the anatomy will be seen only with the help of MRI. So now let's start with the most important ligament in the midfoot, which is the Lisfranc ligament. So this is a cut section which is trying to show you the Lisfranc ligament and all its components. So it has 3 components: the dorsal, the interosseous, and the plantar component. Out of this, the dorsal is not that strong, and the major stability is provided by the interosseous and the plantar components. So now let's try and look those ligaments on our scans. So this is a coronal section of PD weighted images. How would you say that this is a PD weighted image? You can see there is fat appears bright on your PD weighted images. So within the bones, you can see the bright signal, and in the subcutaneous region also you can identify the bright signal. So we are aware that we are looking at the PD weighted images. How are we seeing, how is this section taken? So we are seeing a coronal section. This is cut like this on the ankle. So these are your metatarsal bases. And here we can see all the 3 components. So you can identify this band. This is your dorsal component, which we discussed. Then this is your interosseous component, the thicker band, the most thick, and which provides the maximum stability. And this is your plantar component, which is also provides significant amount of stability. If you trace this, you can see this band going towards the second metatarsal base and attaching over there. So if you do a high resolution, good small FOV images, you can very well see all the components of your Lisfranc ligament. Now moving on to your axial plane images to see the same anatomy. So you need to see your ligament in at least 2 planes, which is the coronal and the axial planes. So this was your coronal plane, which we saw just now. And now we are seeing our sections passing from superior to inferior. So if we try seeing from superior to inferior, we are at the level of interosseous component of the Lisfranc ligament. And you can see how beautifully you can see your interosseous component extending from the cuneiform till the second metatarsal base. And it is hypo-intense. That is, it is dark on your PD weighted images. So we are aware that this is PD weighted image because there is fat seen in the subcutaneous region as well as the bony marrows. Similarly, so this is your interosseous component. Similarly, this is your PD fat suppressed or a T2 fat suppressed image because the bones have become dark. The fat has been suppressed. So once the fat has been suppressed, everything will appear black. So your subcutaneous fat has become black, your marrow fat has become black. So this is your fat suppressed image. Even on fat suppressed image, your ligament would be equally dark. So the moral of the story is that your ligaments will be dark on all the sequences. Any abnormality within them will cause the brightness within them. So we have seen till now the interosseous component on the axial images. Now moving on to the dorsal part. Now our cursor is passing through this level. So we are seeing at this level. So this band which you can see, this is your plantar component of your Lisfranc ligament. And similarly on your PD fat suppressed image, you can again see the plantar component of your Lisfranc ligament. So this is how you can evaluate all the components of the Lisfranc ligament. Except that you can even identify the intermetatarsal ligaments on your MRI. You can identify other tendons. This is your peroneus longus tendon. You can identify all of your tendons like we discussed before, which provides stability to your foot joint, midfoot joint. The important point to notice here is that between first and second metatarsal, there is no intermetatarsal ligament. So the main stability is provided by the Lisfranc ligament, and that's why it is very important. And rest of the ligaments, rest of the metatarsal bones are connected by the intermetatarsal ligaments. So this is important. That's why whenever you would be noticing in Lisfranc fracture dislocation, all these metatarsals move together to one side and the first metatarsal stays separate because it is not connected by any intermetatarsal ligament also. So that's why these all move together and this remains separate. Now coming on to the second part of the talk. So we have seen the bony anatomy, we have seen the capsulo-ligamentous anatomy, which is best appreciated on the MRI. Now moving on to the mechanism of injury. So mechanism of injury can be either a high impact injury or it can be a low impact injury. So if a patient comes with a high impact injury, a very high force has been applied to the midfoot, he has faced a motor vehicle accident, then what you're going to see is most commonly Lisfranc fracture dislocation. But if it's a low impact injury like in sports related people, or there is an indirect force, then what you're going to see is your midfoot sprain. So let's deal with each one of them on imaging. So coming on to your high impact injury, which is your Lisfranc fracture dislocation. So your Lisfranc fracture dislocation can be of two types. Either it can be homolateral or it can be divergent. What do we mean by homolateral and divergent Lisfranc fracture dislocation? So these red arrows try to show you force of impact and the yellow arrow shows how the metatarsals are moving because of this force of impact. So if your force of impact is in this direction, then all the metatarsals move together in one direction, leading to homolateral. When everything is moving together, it is your homolateral fracture dislocation. But if the force is between first and rest, then it results in a divergent injury. That is, the first moves in its own direction separate, that is medially, and rest all move in the lateral direction separately. So now let's see. So this kind of an injury pattern can be identified with the X-rays well. So this is your homolateral pattern in which you can see all the metatarsals have shifted towards the lateral side. And you can see your cuboid, this much area is bare and these are not articulating with anything. So this is your homolateral pattern of injury. Then, as we said, this is your divergent pattern in which the second to fifth metatarsals have moved laterally and your first metatarsal have moved medially. So these pattern of injuries can be identified and well picked up with the radiographs, which is the first modality ordered in the casualty if the patient lands up with this. Then coming on to the low impact injury or the midfoot sprain, the mechanism of injury again depends upon the direction of force. So your foot is plantar flexed and a rotational force is applied because of the planted foot. A rotational force is applied which results in injury to the Lisfranc ligament or it can be an axial force which is directly coming down to your Lisfranc ligament and causing it to get torn. In both the mechanism, the Lisfranc gets torn, and because of the direction of force, the rest of the metatarsals move in the dorsal direction. That is, they'll shift up. So these are the two mechanisms of injury. So how would, if somebody comes to you with a midfoot pain or a history of midfoot injury, or sports person, so if you are, the first modality of investigation usually is the radiograph. What exactly we are looking at to look for Lisfranc on a radiograph is, you should always see that your metatarsal and the cuneiform lateral border are in alignment. So your medial cuneiform and first metatarsal lateral borders should be in alignment. Similarly, your second metatarsal base and the middle cuneiform medial borders should be in alignment. If this alignment is lost at any point in time, you are suspecting an underlying Lisfranc injury. Also, in addition to that, the distance between the two should not be more than 2 millimeters. So these are your things which you have to figure out on your radiographs, which you are ordering first. And especially emphasizing at this point, your radiographs should be weight bearing, because they will help you to pick up the Lisfranc injuries much more better. So now let's see an example. In this, you can see the medial border of the second metatarsal base is here, and your medial border of the middle cuneiform is here. So it has lost its alignment, and you can also identify that the gap has increased as compared to the normal, which we saw in the previous radiograph. So this is a Lisfranc injury. Then again, in this example, here again the alignment is lost and the distance is significantly increased. So this indicates that there is an underlying Lisfranc injury. On lateral radiographs, while we were seeing the mechanism of injury, we have studied that second to fifth metatarsals move in the dorsal direction. So that point we can identify on our lateral radiographs. So on a lateral radiograph, if you drop a line between the metatarsal and the cuboid, the line should be in one plane. There should be no malalignment between the metatarsal and the cuboid. So let's see an example. If we see this, you can see how the metatarsals have moved dorsally as compared to your tarsal bones. If you are seeing this, again, you are suspecting that there is an underlying Lisfranc injury, and obviously you will have your AP radiographs which will show it much better. Now coming on to so you did a radiograph and you didn't find any obvious injury, but the patient is in severe pain and you suspect that there is a Lisfranc injury. So you will order an MRI. While ordering an MRI, you should try to look focused on the midfoot. Otherwise, the whole foot, like we have been repeating this before and after, otherwise whole foot would be covered and you will not be able to see deep down into the Lisfranc or the midfoot area properly, and you may miss on those areas. So the technique has to be proper to have a proper look into the ligament. So like we saw, they look dark black on all the sequences, but in this case you can see that the signal has become a little brighter. So this is your PD and this is your fat suppressed image. Again, you can see the signal has become brighter, and your clue on bone marrow edema. So you can see a little bone marrow edema in this cuneiform bone as well at the attachment. So this again suggests that there is an underlying Lisfranc ligament injury. Although the fibers are continuous, but there is little edema in the fibers, and there is an adjacent marrow edema. So all these point out that there is a low-grade injury with continuous fibers with a subtle marrow edema to a low-grade Lisfranc injury. Now moving on to another case. This is your coronal image, which is cut in this plane. So here you can see this is your interosseous component, and your plantar component, you can just see edema. And you can also see edema at its second metatarsal base attachment. Again, edema is a very important clue to an underlying injury, and along with it, you can see edema in your plantar component as well. So you move down to your PD weighted images. Here you can see continuous fibers, but there is little edema, little brightness of the fibers. It should be dark black. They are not dark black. They look a little brighter. So this suggests that the fibers are again continuous, but there is a low-grade plantar component Lisfranc injury with marrow edema. So it is important to evaluate it on PD as well as fat suppressed images, because marrow edema also gives you a clue to a low grade injury. Then coming on to another example, in this case, this is the way I cannot see a really well dorsal component here. I really cannot see a very nicely the interosseous component. It looks all edematous, and the plantar component also looks edematous. So what I'll do, I'll go on to the axial images and confirm my findings. So I'm at the level of dorsal ligament. So the red line indicates at what level I'm seeing the axial. So here you can see that there is a lot of marrow edema. It suggests that you are looking for some injury. So there is dorsal component injury as well. Then I come down to the interosseous component and I try to look on my PD and PD fat suppressed image. So on PD fat suppressed image, I can just trace a few fibers. However, anteriorly, I'm not able to see any very nice healthy fibers. Similarly, I move down to my PD image, so I can see a few fibers, and anteriorly I can see this defect and I cannot see a continuous fiber. So this suggests that there is a high grade injury to the Lisfranc interosseous component. So it is important to collaborate all the images. And then I come down to my plantar component and I again see that there is a thick plantar component which is edematous, which is thickened, but it is continuous from here to here. So there is a low grade injury to your plantar component. So you can even classify what grade of injury is happening to all your components of the Lisfranc ligament. Then there can be bony avulsions. You can pick them on MR as well. But on CT, you can see a gross piece here avulsed from the second metatarsal base in a Lisfranc ligament injury. So usually Lisfranc midfoot sprains have been staged into 3 stages. Stage 1 in which X-ray won't show anything, and this is the most important thing where you want to get an MRI and be sure what is going on. In stage 2 also you may see diastasis, but you may want to be sure that what is going on exactly to the ligament. And stage 3 is when you have gross diastasis. So what I have observed with my clinicians, that usually if it is a low grade sprain, they may treat it conservatively. And if it is a high grade disruption of the fibers, the patient would have to be taken for a surgery. So MRI helps us a lot in identifying each and every aspect. Then again, as we thought that all these structures are a part of midfoot, so we have to have a look at all things. So we should always look for any other areas of marrow edema. So in this case, we could find out a third metatarsal base marrow edema, and there was a fracture line running through it. So there was a third metatarsal base fracture, which could be very well and easily identified with the MR. Similarly, this is your cuboid fracture. You can see a lot of marrow edema in the cuboid, and this was your fracture line running through here. This can be missed on radiographs because it is undisplaced, and it means sometimes not well be picked on the radiographs. So it is very easily picked up on MRI. So and this last slide of my lecture is, you can see a lot of marrow edema. This shows that foot has undergone a significant injury, but still we can see only low grade injury to the Lisfranc. So overall with MRI, you can identify the entire spectrum of injury which is happening to the midfoot, and you can even grade your Lisfranc injury. So it is very important to be specifically ordering things. So just to point out that if you're suspecting Lisfranc injury, you should order for weight bearing radiographs rather than a routine radiograph. For looking at the Lisfranc and the midfoot, ankle study would not be sufficient enough to look at them. You have to specifically order a foot, and it would be ideal if you could mention that we are trying to look at the Lisfranc, so that the technicians could tailor down the study and get high resolution images of that area. And a proper interpretation is important because it is going to affect your management. That's it. Thank you.
Thank you, Dr. Ankita. We are actually running short of time, and we have one more talk from Dr. Melanie to go. So I would request Dr. Melanie to finish the talk first, and then we can have a few questions together.
Yes, sir.
For both the talks. Dr. Melanie, please.
Yeah. So let's quickly look at the imaging of great toe. It's about is the PPT visible now?
Yep.
Yeah. Okay. So let's have it's end of the day. Everyone must be very tired. Let's quickly look at imaging of grade 2. We'll be specifically looking mainly at turf 2, that being the primary focus. So again, we need to focus and get high resolution images through the toe. And if we ask for toe, again, specifically targeted to the metatarsophalangeal joint, we can get high resolution images. Quick look at the anatomy. We all know plantar plate, which is a fibrous tissue in which lateral and medial sesamoids are embedded. The central portion is intersesamoid ligament. The distal portions peripherally are thickened. So they're not separate ligaments, but they are just thickened, and they are the sesamoid phalangeal ligaments, lateral and medial. And then we have the abductor hallucis attaching to the medial sesamoid, adductor hallucis attaching to the lateral sesamoid, flexor hallucis brevis, and the flexor hallucis longus passing through it. So this thing can be seen very well on MRI. Again, as I said, it's important to get these kind of images. This is a sagittal image. We can see the sesamoid. So where the sesamoid is just about seen barely, the central portion here is the plantar plate. When you come more laterally, it is thicker, and this is the either medial or lateral sesamoid phalangeal ligament. All ligaments again are dark on all sequences, so you can see them as dark band-like structures. If I obtain an axial image passing through the toe at this level like this, I can see the two sesamoids very well. In between them is the intersesamoid ligament portion. This is the medial and the lateral collateral ligament, and from the metatarsal to the sesamoid is the accessory sesamoid ligament. So we can see all these structures, the intersesamoid, accessory sesamoid, medial and lateral collateral ligaments, as well as the central portion of the plantar plate and the sesamoid phalangeal ligament well on these high resolution images. The whole idea of high resolution is to get the field of view down, take thinner sections, and then you can see these structures very well. Now, few examples. So if we just remember this normal appearance where you have this hypointense line intact, we can see here. And here again, you have a whole ring-like dark, a ring-like band all around intact, if we remember that. Now, if we see in this patient, there is no dark band here. This is the flexor hallucis longus tendon, and you can see there is no plantar plate at all. It is disrupted. This is distal attachment plantar plate injury. Here in this patient, if we look, this is the flexor hallucis longus. This here would be the accessory sesamoid ligament lateral, which is fine. But here if you see the medial, sesamoid phalangeal ligament, because we are a little more distal. So the lateral sesamoid phalangeal ligament is intact, but the medial sesamoid phalangeal ligament is disrupted, and you can see edema in the soft tissue overlying it. So these injuries are common, especially with football players due to hyperextension. Here again, we can see this plantar plate, this thin structure here, and it's disrupted. You can normally see a recess here. So sometimes it gets confusing. Recess is usually very small. There are no other adjoining tissue injury. While if it's a tear, you will see some proximal migration of the sesamoid, which gives us a clue that this plantar plate is torn. Here in this patient, now if we look at it, if we see here, this is the medial sesamoid phalangeal ligament. This is the lateral sesamoid phalangeal ligament, which is intact. It's seen as a black band. But here you can see the small piece. See, can you see this cortex of the phalanx intact, this black line? So on MR, everything is opposite of X-ray. X-ray, the cortex is seen as a dense line. Here, cortex is seen as black. And here you can see a disruption. So this is a small osseous avulsion at the phalangeal attachment of the medial sesamoid phalangeal ligament. Again, here on this image, we can see that small osseous fragment. And in this patient, again, the plantar plate is disrupted. We don't see any plantar plate which is intact. Here, this is a patient who has osteoarthrosis. You can see these osteophytes, cartilage is all lost. And what we can see is that the sesamoid, instead of being located under the metatarsal head, is migrated proximally, which suggests that there is chronic plantar plate rupture and there is some scarring. So there's some tissue out here which is scarring. Here we don't see this sesamoid here at all. The medial sesamoid is present. Here in this patient, on these axial images, what we can see is the medial collateral ligament. So the phalangeal attachment is intact, but as we come towards the metatarsal attachment, you can see this marrow edema. So as I said, marrow edema is a clue which catches our eye and tells us to look at the adjoining structures. So when I look carefully at the adjoining collateral ligament, you can see at this attachment, it is not seen well. It is thickened and showing bright signal. So there is intermediate grade injury of the medial collateral ligament proximal attachment. And this is a pain marker. So we keep a vitamin E capsule at the site of pain. So this helps us to look at that area more carefully and also to tell us that, yes, this is what is causing the patient pain. So here, if we look, this is the two sesamoids. This is the intersesamoid ligament. And we can see the accessory sesamoid and the medial collateral ligament are injured. Here in this patient, we can see the plantar plate injury. There is dorsal capsular injury, as well as a very small avulsion fracture at the medial collateral ligament distal attachment. This is the normal radial collateral ligament, black band. Proximally it's intact, while here there is injury. So if we look carefully at these structures, we can see them well. Sesamoids can be evaluated very well with MR. So radiographs, we all know, we use these views and this view to look at sesamoids. MR can pick up marrow edema in the sesamoid even before there is any abnormality on X-ray. So here there is stress edema, sesamoiditis, what you would call it, in the lateral hallux sesamoid. Medial hallux sesamoid is normal, and this suggests stress edema in the sesamoid. This patient here has got fracture in the medial sesamoid. This is the normal lateral sesamoid for comparison on the sagittal image. And here you can see these jagged edges. So there's fracture, and this marrow edema tells us that it is acute. So on FAT-SAT-T2, if we see any bright signal, it tells us this is acute. If this was a chronic one, we would not see this marrow edema. You can see normal sesamoid here on this axial image, and here you can see fracture in this sesamoid. Bipartite sesamoids could be there. So how do we distinguish them? Bipartite sesamoid have very smooth margins, unlike fracture, which we saw has more irregular, jagged kind of edges. Also, the bipartite together looks much bigger as compared to the normal sesamoid. So this patient had bipartite sesamoid, and then on MR, you can see marrow edema. So there was bipartite sesamoid with stress edema in the sesamoid. In this patient, if you look, this is the normal sesamoid. And now you can see this sesamoid shows a fracture, and it's completely dark on all the sequence. This is a proton density sequence. This is T1 weighted image. This is T2 weighted image. It's looking dark on all the sequences, suggesting sclerosis, and it has undergone osteonecrosis. You can have osteoarthrosis at the sesamoid metatarsal joint also. We looked at these normal, if we look at it, you can see here the cartilage is seen well and smooth. But now here in this patient, you'll agree there are these osteophytes. The cartilage is, normal cartilage is gray. Here you can see the cartilage is lost. There are these osteophytes, and there are these subchondral cystic changes in the lateral sesamoid and the adjoining metatarsal. You can also have pain in the forefoot area because of intermetatarsal bursal fluid. So you may see fluid. Many a times this is just asymptomatic, but if we don't find any other cause and the pain marker is at that location, then intermetatarsal bursa could be causing toe pain. Here you have marked osteoarthrosis of the first metatarsophalangeal joint. You can see these large osteophytes, cartilage loss, small ganglion is formed. Here again, you can see the plantar plate is completely ruptured, chronic, and there is osteoarthrosis. You can see the cartilage is completely lost. Here it's an early stage. So something like this would obviously be visible on the X-ray also, but here on MR, you can see this marrow edema, this little cartilage fissuring, subtle cortical depression, and some subchondral cystic changes. So MR can help you detect these early stages which would not be seen on X-ray. Gout can be seen as some joint effusion, marginal erosions, and these tophi. So whenever you see the tophi, they are seen as dark, soft tissue, periarticular kind of lesions, and that is classic in gout. If it is ganglion, metatarsal bursa, intermetatarsal bursa, they will all be bright. These are dark on all the sequences. Stress fracture could be a common cause of pain. And seeing this extensive marrow edema adjoining periosteal muscle edema, sometimes we get confused, is it infection? So many a times we see that some people may wrongly interpret this as infection. But when we look carefully, you'll always see that little area of early callus formation, periosteal reaction, that stress fracture area, which is better seen on CT. But even with MR, you are able to demonstrate it. But yes, if it's not seen on MR and you want to differentiate just stress edema from stress fracture, then at times CT would be helpful to show the fracture line better. You can also see subchondral fracture. In children, this would be Freiberg fraction, osteochondrosis. In adults, what we see is flattening, and you see this subchondral fracture. So you have this subchondral fracture, lot of marrow edema, reactive joint effusion. So getting these kind of high resolution images are important. Otherwise, these kind of diagnosis would not be possible. So kind of just to summarize it all, the most important thing is high resolution imaging, only forefoot imaging. Pain marker should be placed, because then sometimes you may see incidental Morton's neuroma, incidentally you may see metatarsal bursal fluid. So when we know the pain marker, we can report that this is the finding which corresponds to the pain marker. And we need to know the anatomy well. Once we know the anatomy, it's really not difficult to find out the abnormality and then decipher what the pathology is. Any questions? I would be happy to answer.
Thank you, Dr. Melanie. There's one question from radiologists. I don't understand the term FOV. It shows what FOV should be used to evaluate the great toe. With smaller FOVs, that is less than 130 millimeter, we get a lot of fold over artifact, and how to avoid it.
Yes.
I'm sorry.
So FOV is field of view.
Okay.
How much are we including?
Okay, I don't
Whether we are taking a large panoramic
it.
kind of view or a small.
Okay.
Yeah. So field of view. So as I said, what we usually do is we start with a larger field of view where we include the entire foot so that we are not missing anything else. But then we reduce the field of view. So as somebody said, below 13 centimeter, they get artifact. So there's an artifact which is called as phase wrap. If they are talking about that, that should not be a problem, because there is a particular command, no phase wrap, which can be applied, which will increase the time a bit, but it will avoid that artifact. But having said that, you can't go very low on the field of view based on the machine. If the machine, in the lower field strength machine, if you go too low on the field of view, you can start getting more grainy images. So you'll have to keep a balance. But ideally, the field of view should be as small as possible to cover the area that you are looking at.
There's another question. If the interosseous part of, this is probably to Dr. Ankita, the interosseous part of the Lisfranc ligament looks torn, but the plantar part is intact. So how you grade that injury, and what are your suggestions to the treating surgeon?
So what we are seeing on a MRI scan, we have to report it like that. So which ligament, how much it is injured, how much amount of fibers are involved. So we exactly figure out what all is involved and how much. But final decision on how to manage the patient has to be taken with a clinical component as well. We have to judge whether the patient is having instability and how much instability. So it's not only the MRI which will decide the treatment. It is obviously the clinical component in addition to the MRI which will help us decide our management. So and on MRI, you need to identify the injuries and to grade each component injury, but the final decision has to be taken along with the clinical insight.
In the other words, is there any way of grading the injuries, ligamentous injuries, Lisfranc ligamentous injuries on MRI? On MRI, you showed the Nallian classification in that. The one diastasis, two to find that is more of an orthopedic classification.
So usually how we grade the injury is we call it as a low, intermediate or a high grade injury. So low is when you see the continuous fibers and there is only edema, like which I show 2 cases of that also. So there is, the fibers are continuous. Intermediate and a high grade injury on the other spectrum is when the fibers are completely gone and torn. So you don't see the continuous fibers, and intermediate is something between the two. So this is not like a standard thing. It's again a visualization thing, and how continuous fibers you can see, and the continuity is the fibers which will make an impact on the stability of the joint.
Thank you, Dr. Ankita.
So essentially, MR is a demonstration of the degree of distortion of tissue, and how that degree of distortion of tissue manifests clinically in terms of actual instability, actual abnormality in a clinical picture, and pain are two separate entities. Oftentimes, a greater degree of distortion is more likely to correlate with a higher likelihood of instability, etc. And a lesser degree of distortion is less likely to lead to instability and the other associated problems. So you're providing sort of a crutch to everybody towards making those decisions.
One more question. How can we differentiate between the septic arthritis and the osteoarthritis of the ankle radiologically?
So infection, okay. So in infection, we'll see synovial thickening also. We'll have effusion, we'll see synovial thickening, subchondral marrow edema, as well as periarticular soft tissue edema. In osteoarthrosis, you may get synovial thickening as reactive, but it will not be to the same extent as with infection. And also clinically, what the patient is presenting with, you'll see erosions and all that. So usually infective versus osteoarthrosis is not a problem. Infective versus inflammatory is something we may not be able to make out on MRI.
So we had quite a bit of discussion. This is last question from my side. How you pick the Morton's neuroma? In it's a very difficult diagnosis to make when it's more of a clinical diagnosis.
So I didn't include that because it said great toe, but just where I showed the intermetatarsal bursal fluid. So on those axial images, in the intermetatarsal space, we can clearly see a teardrop shaped soft tissue. We can differentiate it from bursa because bursa is like fluid. It will be bright on T2. While Morton's neuroma will not be that bright. We usually do not need to give contrast or anything. Plain scan is enough, and we are able to identify that soft tissue with this resolution. Some people talk of doing a scan in a prone position because then that space widens out. You can see it better. But frankly, we can see it well on ultrasound as well as on routine MRI with these images. We can trace the digital nerve.
So we can differentiate between the intermetatarsal bursitis and in this because that
without
is
any contrast study on the plain MRI.
We can. Anyway, thank you very much to Dr. Daftari, Dr. Melanie, and Dr. Ankita. I know we have overshot the time, and I really apologize for it. Sorry for it, but I hope that everyone has enjoyed the interaction, and it was really great to be associated with you as an IFAS president. And I would, if Ajoy is here, Dr. Ajoy, you are here? Dr. Ajoy? I want... No, I think he is busy, so I wanted our secretary to say thanks to you. But anyway, it's a thank you very much, Dr. Daftari, Dr. Melanie, Dr.
Thank you very much for having us. Thank you, Dr. Rajiv Shah, also for connecting us with all together. Thank you, everyone.
Thank you very much. Thank you.
Thank you, everyone. Thank you so much.
No, he's here. So I was asking.
I'm very much here. I'm here. Okay. I just switch off my video.
I just wanted you to say convey thanks to everyone.
Oh, okay. I've been here only.
Okay, I've done your part. Okay, then see you.
All right. Thank you.
Thank you. Good night.
Right, ma'am. Thank you. Yes, sir.
ठीक है रे.
Right.